Hello, hello, hello. Welcome to 51 Labs, to the final showcase. I am Stephen Collins. I'm the CEO of Matter, for those who I don't know. Thank you, everyone here, for joining us. Thanks to those of us who are joining us virtually. Our mission at Matter is to accelerate the pace of change of healthcare. We do several things in service of our mission. So one is we run an incubator for healthcare startups. We launched in 2015. We've supported about 1,000 companies from all over the world. They range from very early to growth stage companies. Our companies in aggregate have raised about $5 billion to fuel their growth. We also run accelerators, relevant to today. We run 6 to 8 a year. They're all in partnership with health systems, with life sciences companies, with payers, with associations. And we work with large enterprises to help them build their innovation capabilities. We have a suite of education and training and insight services that help them make sense of emerging technologies and figure out how to harness them. And we're a nexus for people who are passionate about healthcare innovation. We bring people together to be inspired and to connect and to learn through events such as this one. So every year, we run an accelerator that is focused on women's health. Last year, we focused on menopause. This year, we've been focused, obviously, on maternal mortality. The maternal mortality rate in the US is, as I imagine you all know, shockingly high, unacceptably high, compared to every other developed country in the world. And it just keeps going up. And while it is bad for all ages and races, it's 3 times worse for black women, which makes it more akin to a developing country experience here in the United States. Which is why we wanted to run this accelerator on this topic, to identify and support companies with solutions that can reduce the maternal health crisis in the United States. We found 7 organizations to partner with to make this accelerator a reality. Sometimes we run accelerators with just one company, one health system, one partner. This time we brought in 7. These are all organizations that are committed to improving maternal health, to reducing the maternal mortality rate in the US. HCSC is the largest customer-owned health insurer in the country. They operate Blue Cross Blue Shield plans in Illinois, Texas, Montana, New Mexico, and Oklahoma. Organon is a leading life sciences company focused on women's health. Stryker is one of the world's leading medical technology companies. University of Chicago Medicine, Parkview Health, BayCare are 3 extraordinary health systems in Chicago, Fort Wayne, Indiana, and Tampa, Florida, respectively. And the Laerdal Million Lives Fund is a venture firm that's committed to making investments that will result in 1 million lives saved every year by the year 2030. We have been very fortunate to have these 7 partners to make this program possible, to advise and guide and support the startups both during the program and also what will be on an ongoing basis. So each company had the option to take a $100,000 investment from the Laerdal Million Lives Fund. Each company also received $25,000 worth of services from Matter, including a 6-month Matter membership following the accelerator so that we can continue working with them to support the development of their businesses and their access to capital and their access to the customers that they need. We've had 2 amazing mentors guide the journey for the cohort, Pam York and Nicole Walker, who have decades of experience operating, investing in, supporting startup ventures. They look like they're just out of college, but really they have an incredible amount of experience. Beyond our partners, beyond our lead mentors, we've had a great group of healthcare executives volunteer their time to help the cohort to advance their businesses. Thank you to everyone who was involved and who really made this program what it is. We're going to hear from each of the companies today, but before we do that, we are going to hear from Dr. Elizabeth Cherot, who is supposed to be with us. She's the president and CEO of the March of Dimes, which is one of the most prominent organizations in the world fighting for the health of moms and babies. She unfortunately had an emergency situation. She was supposed to fly in, she couldn't. So she did record a video that we're gonna watch. So I'll just tell her a little bit about her, and I'll give her a nice introduction as if she were here, so you can tell her that I gave her a nice introduction. She was appointed to her her position about a year and a half ago. She's the first physician leader in the 86-year history of the March of Dimes. She's an OBGYN who was previously the chief medical officer of Axia Women's Health, which is one of the largest fully integrated women's healthcare groups in the US. She oversaw more than 2,500 colleagues, 500 providers, 200 patient care centers across 5 states. She's practiced medicine, she's managed groups, she's taught students and residents since graduating from University of Rochester's Medical School. She also has an MBA and a BA from Johns Hopkins University. We are delighted to be able to work with the March of Dimes, to consider them in our quarter, to support what they're doing. They support what we're doing, and we're sorry that she can't be here today, but again, we'll hear a little bit, sort of an abbreviated version of what she was gonna say, and then we'll get into the pitches. So thank you again. Thanks to all of you for being here, for participating, for making this possible. And with that, I'm gonna turn it over to who is gonna be your MC for the program, Casey Sheridan, who is on our partnerships team, who has really been the point on this program, who really put this together. And the first thing she's gonna do is play a video, but then she'll be here to MC the program. So thank you, and thanks to all of you.
Thank you, and thank you for having me today. I'm sorry I'm not in person, but wanted to give some highlights from the March of Dimes and our 86-year history. So I'm Dr. Cherot. I am the CEO and president of the March of Dimes, and as you, I think, all know in the audience, we are a non-for-profit that has been trying to solve for the maternal and infant healthcare crisis. We started, right, by FDR back in the 1930s, solving for polio, which we did, right? And we asked every American to send in a dime, which is part of how we became the March of Dimes. And FDR did that first crowdfunding, which is why he's on a dime, which is sort of cool history. But I'm really here to dive into kind of where we are, the state of where we are, and then also a little bit about the programs we do, which our Innovation Fund is part of, which is a philanthropic venture capital arm. And so love that you guys are all pitching today. I wish I could have been there in person, so my apologies. But we're going to start moving through these slides because I know I only have a few minutes. The US remains one of the most dangerous developed nations to give birth in. And we're actually ranked 55th by the WHO because 2 women die really, every day. And 2 babies are dying every hour in the United States. And we are going in the wrong direction when you start to look at the data and the trends. And you probably know that at themarchofdimes.org, we do a ton of work in the data. And in this space, we talk about maternity care deserts where there is no provider, there is no hospital or birth center to deliver or be taken care of. So I encourage you all to go look at our website. Our mission is really, we want all moms to have a healthy outcome, no matter their race, no matter their gender, their geography, their wealth. And that we really know there are so many barriers, and we are really putting programs together to affect this change. So when you start to look at this from a health equity lens, it's even worse. So when you start looking at inadequate prenatal care, preterm birth, even infant death, I'm always heard as an obstetrician that Black babies are 2 times more likely to die before their first birthday compared to their white counterparts. This is what we talk about when we talk about the health equity gap, and what we're trying to solve for. Because we solve for Black and brown moms and babies, we solve for all moms and babies. So I'll get into this, but I think and actually the 22 data just came out by the CDC. This is the gap that you see here on the screen. And our mortality rate is really going in the wrong direction. And you start to say the why. It's because we're not prioritizing moms and babies in this country. And I do see that as a window of care. So we'll get into a little bit with some of the solutions, but I do want to show you the preterm birth rate. Yes, we've done kind of bounced back up, but we still have 1 in 10. So I always talk to my family that is really 10% is our preterm birth rate. We are getting better at mortality because we've done so much better in the NICU, but we really have a lot to try and accomplish. When you look at this, we know it's a provider issue. We know that providers aren't going into rural areas. In fact, people aren't going into this specialty. That has happened before COVID. That certainly accelerated through COVID as burnout is happening, and then the Dobbs decision. And then I'm going to fly through some of this about hospitals and birth centers. We know that they're shutting down in rural areas. And again, that's on our maternity care desert report. And it's kind of unbelievable the counties which we see. Our maternity care desert, 30+% in our country are actually maternity care deserts. We know that we need to have access to care, and that's really key when it comes to health insurance, right? We need to get these patients, because we all know the uninsured do not go and get care. And women who are in that childbearing age are about 11%. So we have a lot to do. And again, you can see all of this data on our website. And our goals are crystal clear. We want to end preventable maternal and infant morbidity and mortality, and we want to close that health equity gap. When we do that, and I think about this very clearly as an obstetrician, we want to be in that antepartum space, labor and delivery, as well as postpartum in that neonatal intensive care unit. And infant is really considered the first year of life. We want to improve access to high quality care. We're aiming at really the causes. For some of the biggest causes for maternal morbidity and mortality is cardiovascular issues, as well as preterm birth. And so that's why we've really narrowed our focus here. And when I lean in, and I often say this to people, who or what is the March of Dimes? We are a convener. We bring people together, whether it is donors, as well as corporations, fund, foundations, and providers and patients together to affect change through kind of our 4 pillars of what we do. Our research and our data, which I highlighted a ton. A lot of our programs were like boots on the ground, neonatal intensive care unit, supporting patients where they are. We also have mobile units where we actually bring providers to patients. Think of it as a pop-up clinic. We do a ton of advocacy. I actually got to testify on the Hill last summer, and we do a ton of education, and all of that is actually on our website and free. Our report card I highlighted, and I really think it is the data that we produce that is incredible. This is really gets launched every November, and we get into grading this country on preterm birth and our birth rate. And I think every state gets a report. People look for this in November on World Prematurity Day. The other aspects of what we do is that maternity care desert report. I think when you see our data visualized, it's down to the county level. Our next one comes out this September and is on metro areas. And you might say a metro area is a maternity care desert. Yes, we have counties in this country. Actually, about 40% of maternity care deserts that exist are actually in cities. And if you think about it, it's a patient that needs to get a subway or a train and travel differently and may not be getting care, and they're actually not that many miles away. So lots of data that we're coming out with that. We have prematurity research centers. This is the foundation of what we do across this country, trying to solve for preterm birth. I'm a doc. I've been doing this for almost 30 years. We don't have a lot that's changed for preterm birth in this country. So really excited to see us investing in this research. We do have a maternal health equity center. It's inaugural that we started last year at UPenn. And then we have our NICU family support, which I highlighted. We really get patients where they are, doing an incredible job screening for maternal mental health right at the bedside. You can imagine the trauma of going through an emergency birth that might be preterm, or thinking, you're going full term and then within 48 hours you're delivered. It's can be shocking. And we are supporting both patients and their families and professionals right in the neonatal intensive care. These are our mobile health units right now. We have several of these launched across the country, like in Arizona for the Native American population, in Ohio and Appalachia, and actually in New York at Presbyterian Hospital as our partner there. And many more to come. I'm more excited to see launch in the next year. And then lastly, we've really launched our low dose aspirin campaign, which is a campaign that you'll have seen, I hope, came out in May, and we're launching around really a simple, to get baby aspirin in the hands of patients, and we want patients to ask if they're right to be on it to prevent preeclampsia. 1 in 25 pregnancies is complicated by preeclampsia, so it's a huge opportunity for us to really educate patients, professionals, and then do a quality and improvement initiative, which we're launching actually in 25. So really excited, and actually we've got Allison Felix as our spokeswoman, who's just outstanding, and her halo effect of how she affects others for what she's been through with her Nike contract and her labor, because she too had a doula, which is part of another project we have with this multi-year combination with CVS Foundation, and we're really doing training, retaining, and supporting doulas throughout their career, and how do we support them with patients. So exciting to see that launch. And then we have our innovation fund. So I flew through that to get to here because we have 3 companies we've invested in. You're going to hear a 4th very shortly, which is exciting. And really, we have a white paper that we've looked at to think about how we stand this up. And we have donors who are in our investment committee who are really from venture capital and private equity. Then we've got a health science committee that are really our OBGYNs and our pediatricians and our scientists across the country. And we really have a neat juxtaposition to bring them together to use investment and into companies that we really hope bridge the gap, right? That they don't fall into that, for failure, right? We want to see them succeed and get in the hands of patients sooner. So we have Iron Health, which is wraparound services in the OBGYN space, really trying to support patients who are that high risk, who then need help with cardiovascular disease or maybe diabetes or mental health. And then we have radiant oximetry, which is a monitor that is actually on labor and delivery that we hope will lower C-section rates. Really excited to see that launch, as we don't have a lot in that space, at least as a provider. And then Paramus, which is a continuous blood pressure monitor, which actually is on neonates. And actually the first patient up at Tufts University used it just recently, and really excited that avoids actually an invasive procedure in the neonatal intensive care unit, but also the data collection is fascinating. So really excited to see those take off. And our venture capital fund really move the needle in the women's health space. We really want to get these technologies in the hands of people sooner. So listen, how can you help? How can you join us? Join us by fundraising, come and volunteer with us. We have some great events, whether it's a gala, whether it's a chef event. You can get on our social engagement. We've got in Chicago actually coming up in June, we have our MBAN, which is our Mom and Baby Action Network conference. Lots of opportunities to get involved there, and come to our website and download our data. We would love you to amplify and share. So thank you very much. I appreciate your time, and have a great day. And I'm so sorry I couldn't travel today, and wish you guys all the best of luck. This is my contact information, and would love to hear from all of you as you're kind of, going along this road. I come from, prior to coming to the March of Dimes, I worked in private equity. So I get this craziness of what you're all trying to do, and all excited about how we're trying to align together. So thank you very much, and take care.
All right. We thank Dr. Cherot for recording that and for joining us virtually today. Like Stephen said, I'm Casey. I've been running Point on the 51 Labs program. Thanks all for being here today. I'm going to be your MC for the rest of the afternoon. So we are going to get started with the pitches. We have 10 startups who will be delivering a 7-minute pitch each, followed by 5 minutes of Q&A with our 3 expert panelists. Before we get started, I'm going to actually ask our 3 panelists to go ahead and do a really quick introduction of themselves, and then we'll get started with the first pitch. Dr. Lawson, do you want to go first?
Sure. I thought you were going to introduce me. Good afternoon, everyone. For those I can't see, I'll just stand up really quickly. I'm Yolanda Lawson. I'm OBGYN by specialty. I'm the Executive Medical Director for Maternal Health with HCSC, and really happy to be here. I love innovation, so I'm excited.
Hello, I'm Ethel Massing from Parkview Health. I'm the Director of Innovation in Parkview Strategic Enterprises. We've been a Matter partner for many years, and we're just excited to be part of this.
Hi, I'm Colby Holtzhaus. I'm here from Organon. I run our medtech commercial organization. So Organon is a large life sciences company. We have a lot in contraception and fertility, and then a focus in postpartum hemorrhage with our medtech business. So it's really exciting to see so much innovation today in the maternal mortality space. So thank you all for being here.
All right. Thanks to the three of you for being here. Okay, we're going to get started with our first pitch, which is Barry McCann from Nua Surgical. Barry.
Thank you. Good afternoon, everybody. My name is Barry McCann. I'm the founder and CEO of Nua Surgical. We're an Irish startup, and our journey began about 7 years ago when we identified the unmet clinical need during the BioInnovate Ireland Fellowship. And ever since, our goal has been to make a positive impact on maternal health. First, let me tell you about our why. There are over 300,000 largely preventable maternal deaths around the world every year. Here in the US, maternal morbidity and mortality are on the rise, with significant social and economic burdens attached to them. In addition to this, the risk factors that are leading to these complications are also increasing, so something needs to change. At Nua Surgical, we plan to be part of that change, and we're starting by making C-sections a safer surgery. They've become the most common major surgery in the world, currently accounting for about 30 million births each year. And although it can be a life-saving procedure, it brings additional risk of hemorrhage, infection, and even death, as opposed to a vaginal birth. Now, the unmet needs that we're tackling are multifaceted, but it starts with a lack of innovation in obstetrics and no specific tools that are being tailored for C-section. This results in poor access and visibility during the procedure, and it leads to longer, more complicated surgeries, and this all contributes to higher complication rates. In addition to this, these risks are magnified in patients that have a higher BMI, which is extremely concerning given that today, over half of European and 2/3 of US C-sections are being performed in either overweight or obese mums. It goes without saying that these complications negatively impact the patients and their families, the clinical team, and of course the healthcare systems as well. So we're planning to address this unmet need by working with obstetricians for the last number of years, and we've developed Stericision. It is the only self-retaining surgical retractor that is specifically designed for C-sections and which can also address the challenges of high BMI patients. It is a sterile, single-use disposable designed for safety, ease of use, and adjustability. This simple animation shows how its ergonomic design mimics the natural hand movements of an obstetrician, and the soft touch paddles can be adjusted to the visualization needs on each patient's anatomy, enabling safe delivery of the infant, repairing tissue, and crucially, identifying bleeds. So what difference can we make? Well, Stericision is designed to target the risk factors that lead to these complications. We focus on improving visualization, on reducing procedure time, reducing wound complications or excess wound trauma, and reducing bacteria transfer into the wound. These are all measurable outcomes, and by tackling these, we have a significant value proposition to each of those key stakeholders that I mentioned previously. There's no doubt the market is ripe for disruption, since all existing solutions have significant limitations. This provides a prime opportunity for Stericision to become the gold standard for safer C-sections, regardless of a patient's BMI. Many of our value propositions are already validated through our extensive R&D activity. This has included 5 preclinical studies and has given us the confidence to lock in our final design and material selection. We have an established quality management system and a clear regulatory pathway following our early engagement with the FDA. We also have a defensive IP strategy. The device has granted US and European patents, and we have pending patents spanning 6 continents. We're also very proud of the global validation and recognition that our innovation has achieved. This has fueled our early R&D activity through non-dilutive grants and prize funds. We've established relationships and partnerships with US healthcare systems. And most recently, we were announced the Emerging MedTech Company of the Year across all industry in Ireland. Moving forward, we have a very clear development roadmap and a go-to-market strategy. We're currently raising and about to close our $7 million Series A, which enables us to establish our manufacturing line, gain FDA clearance, and begin commercializing here in the US. Globally, this is a multi-billion-dollar market opportunity, but the US will be our entry market due to the clear regulatory and reimbursement pathway and the strong clinical demand. We already have key opinion leaders and clinical champions lined up to run post-market studies in their hospitals once we gain FDA clearance. And our ask from the accelerator and the people here, for the clinicians and for the industry leaders, if they want to be among the early adopters of Stericision, please reach out. To make it all happen, we have an experienced team with over a century of leadership experience in the industry. This includes our board chair, Dr. Elizabeth Garner, who is a globally renowned women's health thought leader. We're also backed by a world-class team of clinical and commercial advisors. So let me leave you with this. We would all like to see a reduction in unnecessary C-sections. However, for those that need them and require them, mothers, their newborns, and the clinical team, they all deserve the best tools and instruments that can ensure a safer delivery. And that is what. Thank you.
Great job, Barry. Okay, we will take questions from our 3 panelists.
First of all, do you have one here with you?
The device?
Yeah.
Yep.
Thank you. If you could pass that to us.
Yep.
Secondly, so can you talk to me, and I don't know who you consider your largest competitor, but let's just perhaps Alexis-O, we use that one commonly.
Mm-hmm.
We have Book Walters, we have other retractors. What do you feel is the difference for yours? And my second question is on the rigidity of this for us to fit this and the adjustment. So it is adjustable, your ring, the rigid portion?
So the ring is fixed, but I suppose when we look at our competitors, you've got a clinician's hands, you've got handheld metal retractors that were invented over 100 years ago at a time when about 10% of C-section patients would have died from the procedure. And then you've got the O-ring disposables, such as the Alexis and some of their competitors. So we've got, I suppose, a number of advantages because this was specifically designed for C-section. So we've taken elements that the clinicians use every single day is a doyen or a metal bladder blade as part of a C-section. So we've taken elements of that, so it's an extremely intuitive device. However, it's adjustable, and we provide that self-retaining element, which obviously when you're having metal handheld retractors in, they all need to come out before delivery. The Book Walter is probably what our device most closely looks like. Mm-hmm. However, a Book Walter is not suitable for infant delivery and not suitable for C-sections. And then when we look at the O-ring disposables, they were never initially designed for a C-section. And I suppose it becomes more and more challenging when you have the lower transverse incision, and particularly when there's a higher BMI patient, because the additional pannus closes down that incision. We quite often will see that additional metal retractors will come in on top of that. So our device, I suppose, it is different and unique based on the ability of adjustment during the surgery. We're not touching the wound edges, so if you need to extend the incision, you're able to do that with the device in place, and quickly adjusted, inserted, and removed. unlike a book quota, which can take many minutes.
Okay, thank you. I won't debate you on those that you just stated. But my other question to that, I can give you some tips after. But my other question to that would be around, I think I just forgot the question. I'll let you ask if you have any, and it'll come back to me.
Sure. Thank you for a great presentation, and it's been great to see the progress in the device. I'm curious as you think ahead to clinical work and then commercialization. Obviously, one of the biggest challenges we just heard from the March of Dimes is the maternity deserts. Payment is not there for childbirth. So how do you think about the value proposition and the willingness of hospitals to invest in an additional device, out of the same payment bundle?
Yeah, thanks, Colby. Great question. And I suppose we do see our value proposition changing to various stakeholders. And obviously for the patient, it's quite different to the hospitals or the clinicians. In the more rural areas and in kind of maternity deserts, if you do not have the resources, again, what our device provides is that 100% self-retaining retraction. So, if it is a limited resource setting, quite often in certain cases that are challenging for C-sections, there are extra staff members that are required to come in. They could be clinicians, nurses, midwives, anybody that's coming in to support in the procedure. We believe that we can reduce that resource requirement, and that, I suppose, not only impacts the clinical team, but the hospitals and the healthcare settings as well. So there's a number of endpoints that we plan on focusing with our early post-market data that we can, I suppose, prove out the value propositions to each of the different stakeholders.
So my question concerns commercialization and adoption. So one of the most difficult things to do is get physicians to change and to use something different. And so how do you propose to do that, to actually be able to get that on the table for them to use?
I think a big part of our 6 or 7 year journey to date has been on ensuring we're listening to the clinicians. So this is designed and developed alongside obstetricians. And we didn't stop on that reiteration until we got that feedback that says, yeah, this will work, this is suitable. And that's feedback from various preclinical studies, device demos, etc. A device that's extremely intuitive, easy to use, safe for both the users and the patient is all key. And that's all the kind of core ingredients that we've had throughout our R&D process. So we're providing an improved surgical tool. We're not changing the procedure. We're not changing the way that they're doing it. We're just trying to make sure that they've got something that's useful.
So I remembered my question. So the O-ring, for instance.
Yes.
Contrary to what you stated, when we first started using that, we were using it for C-sections, and we use it for other types of abdominal surgeries. My concern would be, why would you not, or did you look at this for other procedures? It's almost limiting to think of this as being only branded for cesareans. Was there a consideration for that? And then talk to us about the BMI, low and high BMI in which this was used.
So with regards to the first piece, there is a plan for an extended indication. What we see is the significant challenges that currently occur in C-sections. It's also a surgery that's never going to go laparoscopic. So our focus has been on ensuring that they have a device that is absolutely tailored to their requirements. In some cases, minor modifications to future generation devices, we can extend the indication for other open abdominal surgeries. But at the moment, the focus is to provide a device that's suitable for C-sections. The second question? BMI. The BMI, yes. So we plan to go to market with 2 sizes of the device. And I suppose that the aspect that changes is what captures the abdominal wall thickness. Going to market with that, we plan on using, I suppose, clinician feedback to see whether we need to add one further sizing, but we do believe that we'll be absolutely able to capture at least 80% of those requirements with our 2 sizes.
And is the size difference the ring or the blade?
It's the paddles, yeah, that capture the abdominal tissue. Yeah, the blade is designed to fit all infants. Thank you.
Great job, Barry. Okay, next up, we have Megan Doyle from Parkview Health. Megan.
Thanks, Casey. Good afternoon. I'm Megan Doyle, CEO and co-founder at Parkview Health. This is motherhood. At least that's what I expected. Squishy fingers, warm snuggles, and that really awesome smell from your newborn's head. But the reality is, this is also motherhood. There is a huge range of challenges, complications, and health issues that today's mothers and newborns and families are facing as they go on this amazing life transition. We've heard today about some of the most severe maternal and mortality issues here in the US. But beyond that, there is actually a long tail of complications that ranges from physical challenges with the pelvic floor and other ailments to gestational diabetes, and of course, perinatal mood and anxiety disorders, one of the leading causes of maternal death. We know that gaps in care, lack of access to support for these challenges are leading to difficulties for many families when it comes to their health, as well as to burnout among OBs, pediatricians, and midwives who have to navigate families to the care beyond the scope of their practice today. But now for some good news. As evidenced by forums like this, change is finally happening in maternal health. We are seeing new innovative models of care really taking hold in order to improve outcomes, to eliminate disparities, and to meet the needs of modern families who are looking for a different experience as they enter parenthood. And this is what we're building here at Parkview Health, a new approach that really brings together the care that complements what people are receiving from their OB or midwife. That includes mental health support, birth doula care, postpartum doula care, physical therapy, nutrition, lactation, childbirth education. And we put that all together in a way that's coordinated for families so that it takes the burden off of them having to understand their options and find their way to the care that they need. And importantly, we're delivering that care in the way that families want to engage with the health system. That means we're in person and even in home when that's what's best for them. We offer telehealth and virtual visits across all of our service lines. We provide HIPAA-compliant messaging so people can have continuous engagement with their care team. And we underpin that with on-demand learning, access to evidence-based information that really backs up what it is they're learning on TikTok and, yes, Dr. Google. We know from clinical research that when we step up the support that we provide families, we get to better outcomes and to lower costs. We've been able to move the needle on some of our most stubborn outcomes, including avoidable C-sections, reductions in postpartum mood and anxiety disorders, and even some of our most costly complications, which we heard about earlier, preterm births and low birth weight. Meeting this need beyond the impact also is a massive market opportunity. Today, we know that between non-clinical support, which includes doula care and education, as well as clinical care, which today is largely covered by insurance, we're looking at $40 billion opportunity in spend every year. Perhaps what we're most proud of here at Parkview is that patients really love working with us. We've had a Net Promoter Score in the mid-90s since our launch, and we've delivered that across thousands of visits, and we're now approaching nearly $2 million in care that's been delivered and booked to support families through this period. We're also investing in capturing our own outcomes data, including things like our C-section rate and breast and chest feeding initiation and exclusivity. And importantly, we're really designing around this experience for today's families, being able to help them go from overwhelmed to really supported. We are on a journey today to go from a fee-for-service model, which is how we launched here in Illinois. We currently have contracts with Blue Cross, United, Aetna, and Cigna to provide covered care. And today we're really expanding in two key ways. One is into new geographies. So we're actually live in Houston, Texas as our second market. And also in our deeper relationships with B2B customers. We believe this is really critical to allow us to reach more families and to evolve the model of care and the payment model such that we can move toward value-based care, and importantly, so that we can also serve the Medicaid population. One exciting innovation is that we are seeing an expansion of coverage. For example, here in Illinois, we are hopefully on the cusp of going live with coverage for the Medicaid population for doula care today. Of course, I'm biased, but we have an incredible team, many of whom are here today, so I hope you get a chance to meet them. First and foremost, we are parents. We live this, and we understood the gaps in care that we experienced, even without the challenges of being in maternal care deserts. We have an incredible clinical leader, Dr. Melissa Dennis, who has 20 years of practice as an OB-GYN, and a long list of investors and advisors who have helped us get to this point today. We've also built an incredibly diverse team of providers, more than 100 strong now, across our different specialties of doula care, behavioral health, lactation, nutrition, and PT. And to leave you, I want to tell you about a story of a patient. In fact, one of the first few patients we served. Her name was Jane. She was incredibly nervous about breastfeeding, and she worked with us to prearrange an in-home lactation visit in the postpartum period. When her RN IBCLC came to the house, not only did she help Jane get up the learning curve and figure out how to feed her newborn, which was challenging in and of itself, but she also identified some symptoms that hadn't registered as problematic with Jane. Things like shortness of breath and pain in her rib cage. It was at the urging of this RN IBCLC that Jane went back to her OB to get her blood pressure checked and discovered that she was suffering from postpartum preeclampsia, a potentially life-threatening condition. This is one of the stories that has sparked us to continue on in building this care model and knowing that more continuous and earlier engagement with patients throughout their pregnancy and postpartum really has life-saving impact. Our ask today is simply for connection. If you are interested in partnering in a way that makes an impact on maternal and family health, we urge you to please reach out. We'd love to speak with you. And thank you all for being here today and making moms and families a priority.
We'll take questions. Great job, Megan.
Hi, Megan. So my question's around providers. We all saw through the March of Dimes presentations of these OB care deserts. So it seems like a lot of your services depend heavily on providers. So, how are you getting these doulas? Because obviously it makes a difference, but how are you getting doulas to all your patients and getting that access?
Yeah, it's a great question. So 2 parts to it. I think first, when we think about the OB-GYN shortage, that's actually one of the reasons we believe the evolution of the care model is so critical. And in fact, by working in a really complementary way, we believe that we can enhance the total care experience by ensuring that they have easy access to refer patients to providers who may have more depth in whether it's their physical recovery or behavioral health, for example. In terms of how we're recruiting our providers, I think we've at this point found that people who really have expertise in the perinatal population are incredibly attracted to an opportunity to be a part of a more innovative way of delivering care. So we've done all of our recruiting organically. We do know that with the impending coverage expansion for doula care, that's an opportunity and a place that we've been investing time. So we're working on our own approach to training and certifying doulas. We've been working with an incredible partner who is a community-based organization, and our plan is to launch our first training this summer. So we know that investing in building that workforce and building the skills is an important part of both our growth path, but also really expanding access to doula care.
Thank you for a great presentation. I love your passion for what you're doing. And I'm reflecting that the comment I'm going to make is it seems like there's a number of services-oriented companies, virtual doulas, et cetera, coming into the space. And let's just pause and be grateful that that's the case, because
Yes.
5 years ago, who would have even thought?
Yeah.
But how do you see your sort of competitive differentiation from other organizations that are looking at the same target?
Yeah, it's a great question. I think, first and foremost, we know that while if you follow, women's health and early stage startups, it feels like there's a lot of activity. If you talk to 10 pregnant women on the street, like none of them have heard of us. So we still have a long way to go until we believe the space is overly saturated or competitive. That said, I think one of the things that we do think a lot about is how is what we're doing different and how will we continue to scale and grow. We do believe that healthcare is local, and we're building locally based care teams who really understand the markets, understand the health systems, and we believe that that will allow us to both create unique partnerships, but also serve a portion of the market where in-person care and in-home support really isn't available if you're doing a pure telehealth model. So it's really that combination of being hybrid, being locally based, locally connected, and doing a breadth of services, because some of the other in-market teams that we see are very focused just on, let's say, lactation or just on doula care. But most people, when they're going through this period, like your needs are really interconnected. And so the ability to service in multiple ways, low-level intervention for lactation support from a doula, but the ability to scale up and see an IBCLC when that's necessary. We believe that really positions us to evolve the care model in a way that is differentiated from many of the other services.
I have two questions, but I'll start with one that's clarifying. I don't remember, it was slide 5 or 6. You talked about a 50% reduction in C-sections. Were you speaking on your process in that? And can you help us with what that looks like and how you establish that number?
Yeah, that's a great question. So that slide was actually referencing more the clinical evidence that's kind of the backbone of our model. Specifically, that data was from an Elevance study that looked at doula care for, I believe it was specifically their Medicaid population, and demonstrated the impact of a 50% reduction in C-section rate when doula care was provided to that patient population. So it's really, when we thought about like, what do we want to include, how do we want to serve people, we started with where do we have research that says we can drive impact, and then we kind of layer on that, what is it, the care that people want, where is their demand and interest in the market, and then third, how do we navigate, what's covered, what's paid for, and how to make this accessible for families.
Thank you, that's helpful. And can you clarify for me on your doula models, are they all digital or virtual, or but there is an in-person component?
Yeah.
And the individual can choose what they want?
Yeah, absolutely. So today, it's a pretty flexible model, but we primarily do in-person doula services. So we use a mobile app that keeps people, continuously connected. It allows their doula to also be in connection with other care team members if they're seeing a behavioral health provider, a lactation consultant. But usually they're doing that prenatal planning session in person, showing up to the labor and delivery, at the bedside, and then doing postpartum care, in home and seeing the family face to face.
Thank you.
All right, great job, Megan. All right, next up we have Mika from Malama Health. Mika.
Hello, everyone. Working. Hi, I'm Mika. I'm the founder of Malama. Malama means to nurture or take care of, and we have been on a mission since 2021 to improve pregnancy-related outcomes, and we have been blessed to be joined by the best in industry, in clinical sciences, and in technology to help us on our mission in reducing maternal morbidity and mortality, starting with a very specific focus, which is personal. So a year prior to starting Malama, I gave birth to our first child. I had a high-risk pregnancy. I ended up being induced, but I, N of 1, of course, had in-network access to providers, remote monitoring for my high-risk condition, and of course, a doula who after working with my OBGYN who told me to stop eating rice, I'm Japanese, grew up in Asia, very difficult for me. Finally found a doula who both understood and could work with the needed diet modifications and provided the cultural competency to make me feel less anxious and isolated. And since then, we have built a patient-facing app and provider-facing dashboard, as well as care with this tech wrapped around to serve over 12,000 women with high-risk conditions across the US. And we have heard three things echoed over and over. So while my complication in pregnancy is actually the most common pregnancy complication that most have likely never heard of until either their partner or themselves are diagnosed, we've heard over and over that social determinants, including a lack of culturally competent care, as I mentioned, my OB, who well-intentioned, had only 2 weeks of nutritional education in med school, and advising to stop eating rice was challenging. Food insecurity, lack of access to things like medically tailored meals, and difficulty navigating a health system not necessarily optimized for, as we've seen with the March of Dimes data, for best outcomes. Gestational diabetes, when poorly managed, leads to greater rates of maternal morbidity and mortality by increasing risk of labor obstruction, postpartum hemorrhaging, and poor maternal outcomes. And in fact, 70% of women who are diagnosed with this most common complication will go on to develop overt or full-blown type 2 diabetes, yet there is no regimen for post-GD care, no tailored diabetes prevention program that is specific for the postpartum period, yet rates are rising. And so we started with a very specific problem to solve with an end-to-end care that's mother-centered, culturally competent, and tech-driven. This is a mouthful, but the services we offer are pretty basic. At its core, we offer biometric tracking and culturally competent care coordination and care navigation, with mom at the center of everything we do. Our care is supplemented by technology that is designed by and for moms. We have an NPS of 86, and we've served, as mentioned, over 13,000 patients and are live in over 10 health systems today. This technology on the provider side is also integrated into the clinical workflow. We integrate into Epic and through a partner, Cerner, and has been designed alongside Stanford maternal fetal medicine specialists. And perhaps what we are most proud of is our outcomes. Compared to national GDM averages, yes, there are issues with this, but unfortunately there's not a lot of data. Women using Malama to track and manage their high-risk pregnancy see an 11% decrease in C-section rates, 17% in NICU admissions, and an over 60% decrease in rates of macrosomia, which can lead to labor obstruction and increase maternal mortality rates. We have 2 trials in progress, one with Tufts Medicine with data coming out in the fall, which will be presented at SMFM, Society for Maternal Fetal Medicine, in early 2025. We've set up a wonderful growth flywheel whereby our patients end up referring us to providers, including NPs, clinical diabetes educators, PAs who pick us up and start referring Malama out to the rest of their patient panel. We now touch over 400 clinics and hospitals through this growth strategy. In addition, we're live, as I mentioned, in over 10 health systems and being studied in 2 clinical trials, including one PCORI with UCSF, UCLA, and UCSD. Our team brings the best in the industry, technological experts and clinical expertise. My former boss, who's a former chief clinical officer at Elevance, my background's from United Healthcare and Optum. Our clinical advisor, Dr. Herrero, is an MFM and director of Stanford's Diabetes and Pregnancy Center. Our chief clinical officer, Dr. Wally, and Dr. McKillop, who brings an ex-US perspective, which is also critical in OBGYN with the NHS. Since starting the 51 Labs Accelerator, we've signed 3 managed care plans and are contracted and live with health systems who are paying customers, on putting us on track to achieve about $700,000 in ARR by the end of this year. And we're just scratching the surface. We have 5 more managed care plans in the pipeline. We will use additional funding. We've raised about 2/3 of our seed, went through Y Combinator now 2 summers ago, raised our pre-seed then. We are opening up for $1 million, which will be used to hire additional doulas from the communities that we serve to build and expand upon our technical infrastructure and to serve more women. So thank you for joining us today, and thank you for joining us in our mission to take care of, to preserve, protect our moms, and improve generational health. Thank you.
So I'm curious about sort of the patient funnel and how you are attracting patients. So do you have a contractual relationship with the health systems? So you're selling to the health systems and then they provide the service for free to patients, or like how does the referral funnel work, and then how does the payment work?
Yeah, thank you for the great question. So our model is B to C to B, and then also B to B to C. So the first B to C to B, we've spent $0 on patient marketing. Patients just find us. There aren't a lot of great resources for the biometric track. We have partnered with Dexcom. We sync with Abbott, OneTouch, all of the devices on the blood glucometer side, as well as CGMs, which have recently been just approved for use in pregnancy. So we pull all that data in, make it very easy to sync and track for patients. So patients find us, we're rated, we're the top rated for gestational diabetes on the App Store and Google Play. You can see all of our testimonials and reviews there. And so patients pick us up, they start using Malama, it's free for the patient, and then they share their reports oftentimes with their providers, who then pick us up, refer us to the rest of their panel. And we've seen, and that's been one of our greatest growth engines, is the patient-referred providers, because they're raving about us and providers reach out. We get about 5 inbounds a week from various health systems and providers.
So then who does pay? The insurance
And then the
plans or
providers,
the
if they want to
providers?
access the provider portal, they pay on a license fee, on an annual. And then the plans also pay us about $500 per enrollee per month. Thank you.
So there's been a lot of buzz lately around diabetes monitoring and digital health and diabetes, and how there haven't been great outcomes from that. So it seems like you have good outcomes. So what makes you different than, those huge names out there like the Livongos, that you are getting good outcomes?
Yeah, so unfortunately, thank you. Great question. I know exactly the paper study you're referring to. We've also shared that along with a bunch of the PIs that we're working with for commentary. So we'll share that in a summary form forthcoming. But the baseline is literally pen and paper tracking for women today who have been diagnosed with gestational diabetes, which now affects up to 1 in 5. Among the Medicaid population whom we work with, it's about 1 in 3 women, and that's with our FQHC partners as well, what they're seeing. And our results among the FQHCs who have pulled the EHR data, and we do also patient-reported outcomes, which is how we get all of the other outcomes data. We've seen 14% rates where women using Malama in pregnancy, compared to same population, about 27% for preeclampsia, gestational hypertension, and other. And we attribute that to a couple of things. One is the cultural competency in terms of the health education that happens in between visits. So we really tailor to the patients what they're actually eating. All they have to do is take a picture. We do automatic ingredient detection, pull that out, and adjust and offer real-time tips that are reviewed by registered dietitians that are specific to that patient, what they're eating, and also their portion control. So instead of just having to write down, we actually do that, make it very easy for them to log and get real-time feedback that's engaging and also helps promote health for the long term. And then the second piece is everything we have in the app is available in multiple languages and also available at a 5th grade reading level. So for lower literacy rates as well, instead of getting a stack of papers that you're most likely to just throw out when you get home, we have everything available for you in digestible content, and we think that resonates, which leads to the high NPS score that we see amongst patients. And then the fact that we have the provider pieces too, they promote it, and that if the provider tells, we've seen amongst our data that when providers refer patients, they do have greater, on average, a patient engages with Malama 3.3 times each day.
Thank you for a thoughtful presentation. Could you share with us more of the objective measures? You gave some rates or reduction on C-section, that type of thing, but and thank you for clarifying the population that you're giving those numbers for, because you know that's not national prevalence that you shared with us. But talk to us on objective measures. What would me as a clinician get objectively to know that this is working? Because even the C-section rate, and then also just so everyone understands, gestational diabetes, you could be talking about a population of women who develop diabetes while pregnant, right? And that there's different stages. And then you could be a pre-existing diabetic. And are you teasing those out?
Yes, so the data, thank you for that question. The data that we showed looking at comparing the national GDM average, that's for specifically gestational diabetes, which is the dysglycemia during pregnancy, so that's filtering out the existing diabetes. The outcomes measures that we're looking at with Tufts are the postpartum glucose tolerance test at the 72-hour mark. So we're looking at women using Malama throughout pregnancy versus women who are not, just standard of care, and how they perform on that postpartum GTT at a 72-hour measure. That's the primary outcome, which can be all over the place, so we're setting it up, but secondary are like looking at patient satisfaction and some other secondary outcomes, clinical outcomes. And then our PCORI study with UCSF, LA, that's looking at, it's a comparative effectiveness study. So again, looking at C-section rates, looking at shoulder dystocia, looking at macrosomia, preeclampsia rates, NICU admissions, and a slew of other both maternal and neonatal related health outcomes.
But any objective measures, whether it be weight, whether it be A1Cs, whether it be fasting glucoses, what objective measures are you able to derive from this?
Yes, so we have full glycemic control data both throughout the pregnancy. As part of the diabetes prevention program we're launching, which is tailored for the postpartum, we'll also be looking at HbA1cs, that's an average of the past 3 months, but still we'll be monitoring that. And then macrosomia, so we're looking at what the birth weight is of baby and comparing that. That's where we got the 64% reduction in macros. So only 5% of Malama users have a baby over who's considered macrosomic or large. Thank you all.
Okay, great job, Mika. Next up, we have Christine from VasoWatch. I like the fist bump.
Thanks, Casey. VasoWatch offers wearable machine learning technology in labor and delivery to improve risk prediction for postpartum hemorrhage 10 times beyond the current standard of care. I'm Christine Rowan, VasoWatch's CEO. As we've heard, over 14 million women experience postpartum hemorrhage globally every year. This is a 10% prevalence rate across the population, threatening their lives and their reproductive health. Here in the US, maternal mortality and health inequities are growing. Black women die at 3 times the rate of white mothers, and the US has the worst maternal mortality in the developed world, and it's rising. These are March of Dimes statistics. Hemorrhage is the leading cause of death and complications in that labor and delivery window. And studies show up to 90% of these deaths could have been prevented. It's unpredictable. Shockingly, 40% of the women who go on to hemorrhage are assessed as low risk upon hospital admission. That means that your loved ones are vulnerable. So VasoWatch has developed novel technology to continuously monitor a mother's risk during that labor and delivery window. It consists of a non-invasive wearable worn on the finger, wrist, or chest, a proprietary algorithm, timely risk alerts communicating across the clinical care team ahead of delivery, and easy-to-use clinician dashboards to track the progress. The current standard of care is inadequate. The Joint Commission has mandated this risk assessment survey upon admission, but there's still the onus is put on detection, 500 milliliters or more of blood loss after delivery before treatment ensues. With VasoWatch, you get a safety net. Upon admission, you get a wearable, and you get that continuous monitoring of the maternal heart rate interval timing. If there are changes in the data for that mother indicative of a hemorrhage, an alert is sent an hour or more, up to 6 hours ahead of delivery, allowing time for planning and preparation while the clinical care team is clear-headed and not in emergency mode. And then treatment can be delivered at the first sign of hemorrhage immediately after delivery. With hemorrhage, time is of the essence. So first and foremost, this is clinical decision support technology, so it has to be usable. It's a simple risk indicator going from red to green. And as I mentioned, it communicates across the clinical care team, easy to interpret. We expect we can avert up to 40% of hemorrhages through this technology. We believe we're able to detect myometrial fatigue, which occurs during the course of labor and delivery and cannot be predicted upon admission. We reduce direct variable costs. The severity of hemorrhages costs money in hysterectomies, blood transfusions, extended lengths of stay, $1 million across a health system, which will more than pay for the solution. And given the disproportionate incidence in Black and brown women, we can improve maternal health equity. We can be the voice communicating to the clinical care team. It's affordable. We're hardware agnostic, so the hospital can use existing sensors, existing dashboards, and we can integrate where software is a medical device. And it's a low cost per birth. We expect a subscription rate at the price of a baby shower gift, so less than $150 per birth. So how do we know this works? We conducted an observational study on 525 women in labor and delivery, a diverse maternal population at a large urban Pennsylvania hospital. We compared the VasoWatch algorithm to that of the hospital's risk assessment system. We were able to show up to 10 times the predictive accuracy an hour or more ahead of delivery with the same positive and negative predictive value. So we're reframing the competitive landscape. The focus has been on detection and improving detection for decades. We're reframing it to a proactive, predictive approach given technological advances in interoperability, battery life, wearables, and machine learning technology. Global market annuity, $2 billion global market, $500 million here in the US, where we've heard about the urgent need. And our go-to-market approach will be selling to hospitals and health systems. Ultimately, the payer is our target because we believe we can deliver all those benefits. We'll start by executing clinical pilots to prove the value, and then work through workflow issues. When do you put on the wearable? Just practical things like that. And how do you adjust the clinical practice guidelines with this new physiological metric, which is important because if we don't do this, the clinicians won't use it. One thing I should mention is we do have plans. We've been talking with medtech vendors. They can be clear allies. They have infrastructure actually in the hospital setting. They have equipment we can integrate with. And there are opportunities to expand into the maternity care deserts we talked about. If we have this indicator 6 hours ahead of delivery, we know that when there's an urgency to get the mother to a higher acuity of care. Market expansion also internationally. We believe we can set a new standard in maternity care. Don't want to underemphasize the importance of getting the clinicians on board. If they don't believe this adds value, it will not be adopted. So we're actively working with them. We presented our observational study results at the Society of Maternal Fetal Medicine pregnancy meeting in February to rave reviews. We're actively working with members of maternal quality commissions, patient advocacy groups. The VasoWatch team has decades of experience and obstetrics care, computer science and algorithm development, and business management, and we view things through a health equity lens. Our roadmap is focusing on the regulatory pathway. We expect to be submitting our breakthrough device application within the next couple of weeks. Our version 1 of the product will be done this quarter, and we're working on licensing the technology with a focus on clinical trial, design, and commercialization in 2026. Financial projections call for profitability a year and a half after FDA approval, 60% gross margin, 6% hospital penetration drives a profitable business. We're currently closing out our pre-seed funding round, which is clinical trial prep, and looking toward our seed round to support the clinical trial. It will be FDA de novo approval, class 2 medical device. And we believe women are dying needlessly every day. We have pioneering technology that can save those lives. So we would welcome your support, whether you're an investor, whether you're a clinician, whether you're a health system, or whether you're a payer. We'd love to talk with you and learn how we can support your efforts to improve maternal outcomes and health equity. Thank you.
I'll start. Thank you so much for your presentation. A couple things you mentioned. You mentioned the new physiologic metric. What is the new metric? Because based upon your presentation, it sounds like it's measuring heart rate. Give me all of the metrics it's measuring.
We're measuring maternal heart rate timing. So we've noticed patterns in the maternal heart rate during labor and delivery. So there has to be uterine contractions for the algorithm to be working. And given the intensity of the blood flow during the labor, we have noticed patterns in the heart rate timing, so the P-to-P variability. And there's a definitive change once the mother's, so that's why we believe we're detecting myometrial fatigue, because then the blood vessels aren't constricting properly.
So myometrial fatigue, you mean atony, right? Uterine atony.
Yeah,
Same
it's a form
thing.
of uterine
Okay.
atony. That's why I'm saying 40% as opposed to 80%. Yeah.
Okay, so you said decreased hemorrhage 40%. You're saying that's what you expect. You don't have data yet, correct?
We have our observational study. We will prove that in the clinical trial, yes.
Okay. And in your observational study, how many people were included?
There were 525 people. There were 403 included in the sample, and it was traditional machine learning sampling where we did training and then a validation data set, so we split them in half. So.
And that's where you saw the 40%, or you did not? Can you just clarify for me?
Well,
I'm
we
sorry.
expect our 10 times increase in accuracy occurred in documented uterine atony. And so we believe if we're able to detect that, with a broader population, that this myometrial fatigue portion of the uterine atony we can avert, because you're going to see those signals. There's other placenta egregia we won't be tackling, right? But we will be able to avert those hemorrhages because we'll know ahead of time that the mother's at risk, so we can get ready to treat it.
So I guess that's my question, Christine, and thank you for the presentation. Detection is great to a point of what can you do about it? So other than diverting the mother to a higher level of care, what does that journey look like? What's the different journey that looks like for the mother that you've declared as high risk?
Okay, so if it's low risk, they may have assigned a resident to the mother versus an OBGYN who's had a lot more experience in handling hemorrhages. So there might be some resource allocation amongst the clinical care team by the charge nurse. They may not have completed the whole blood typing process because she's low risk. So they would go further, they would get the blood ready in that they knew that the mother was at heightened risk for hemorrhage. They would look at comorbidities and allergies and select and draw up the right medication for that particular mother. They may not have, in a low-risk mom, they wouldn't have gone that far into the process. They would have made sure that they have all the supplies at the ready. So, the two biggest causes of problem, severity of hemorrhage are that there's late detection or that there's improper treatment. So now, per your clinical practice guidelines, you're ready on all fronts to go through the process, and that mother can be treated as soon as the baby and placenta are delivered.
Great, thank you for the presentation and further answers. And I think, as someone who spent a lot of time thinking about hemorrhage, it is needed to have a better understanding of when a patient is going to hemorrhage or is hemorrhaging. I'm curious, there's a theme to my questions, about the economics of the device. You mentioned $150 per device, which seems reasonable, but then you talked about payers being the sort of primary target as opposed to selling to the hospital. Can you talk a little bit more about that model and how you came to that and how you think the value proposition will work both for commercial and Medicaid payers?
Sure. So we do expect that there will be direct variable cost savings in implementing the solution. Initially, we know some hospitals have innovation budgets and they're focused on maternal health. So they will pay for these pilots. I think ultimately, if the payers are getting the maternal mortality benefits, the maternal outcomes benefits, and the cost savings, right now the bundle's pretty skinny. We know there's enough money in that bundle, but there's other causes of maternal mortality and death. So what we expect is the payers will go through an actuarial analysis and they will see that ultimately this is software. So dependent on the way the hospital chooses to integrate it. And we expect that this will be staged, that initially they won't want to wait and integrate with their existing pulse ox device or EMR. But over time, that'll take costs out of the process. And then, that we're selling a software subscription. And we're selling the enhancements to it, right? So software needs to be enhanced. So we believe that we can be flexible on the pricing. Where it will land, I've got to be, I've got investors that I've got to keep happy here too. But it's not going to be priced in the thousands of dollars range. It's at the price where if I was going after the affluent B2C consumer, they would buy this product. So that's why I'm putting that out there right now.
One last question, Christine, kind of, sort of, because I'm still challenged here. I'm challenged to understand what this adds. I mean, we have pulse oximeters. We have all these tools that we use. People have iWatches that give them, right? You mentioned P2P. We can do EKGs and heart rate. But you also mentioned integration. Who gets the data? Because hospitals, that is a process, right? Because we have our own equipment that is integrated into those vitals. So who's getting this data? Is it coming directly to the patient? Because if the hospital doesn't integrate, and there are barriers to that, and getting into their systems, how do you overcome that? And who's getting the data?
Yeah, I mean, this can operate in our own cloud or in the hospital's cloud through an API. So the data will be in our repository, and we've signed that agreement. Our CTO is in integrated software like this. Over 20 products in hospitals, so we know that one way or the other, depending on how the hospital wants to work with us, we can get this to work. So we're not locally processing, and it's not SpO2. The pulse oxes right now are typically measuring blood oxygenation. We're taking the full waveform. So we need that full waveform to measure the heart rate interval timing. So it is a new physiological metric that we're providing. So a lot of hospitals are adopting labor and delivery dashboards. We can be a new element to that adds incremental value. And again, alerting you hours ahead of delivery that this mother's at heightened risk, something additive to your current risk survey.
So again, answering the question, how does the provider get the data? Who's managing the patient in labor?
Oh, okay, all right,
And
I'm
then
sorry.
the pulse ox that we use measures heart rate also. It does both dually.
Yeah, right now we have a bedside display and a charge nurse station web app, okay? So that would be the turnkey. Ultimately, it would probably be integrated with an existing sensor that you were using to monitor regular heart rate, for example, and with your EMR. Okay, thanks everyone.
Great job, Christine. All right, next up we have Katie from Bax Medical. After this pitch, we'll take a brief break to let you all stretch your legs a bit. So Katie, I'll turn it over to you.
Microphone work? Yes. Okay, good. I'm like getting over a cold, I got 2 kids in daycare and also been practicing this quite a bit, so bear with me. My name is Katie Bazinas, and I'm a founder and CEO of Bax Medical. I'm also a co-owner of Midwest Blood. We're one of the largest service providers of autotransfusion in the Chicagoland area. I'm a recent graduate from the College of Medicine at University of Illinois, and then I'm going to be starting a residency in emergency medicine at Resurrection up on the north side of Chicago very shortly. But before I became an emergency medicine doctor, I was working in surgery, performing autotransfusion for over 15 years. And what this process is we collect the patient's blood when they're bleeding in surgery, and we wash it and we reinfuse it back into the patient. So then they can avoid a donor transfusion. And in 2008, one of my patients passed away from postpartum hemorrhage. And so since that time, I have been trying to think of solutions for that mother and mothers like her. And so we're all here to talk about maternal mortality, but Bax Medical is here to talk about one of the leading causes of maternal mortality, postpartum hemorrhage. So what is postpartum hemorrhage? It's defined as about 1 liter of blood loss within a 24-hour period after childbirth. But what this definition fails to really describe is how unpredictable postpartum hemorrhage can be, and then it can happen within minutes. And this makes postpartum hemorrhage one of the leading causes of death during childbirth in the US and the leading cause globally. So in the US, we're failing to solve maternal mortality. Over the past 25 years, pregnancy-related deaths have increased by 157%. And the rate of maternal mortality is 2.5 times higher in the US than other high-income countries. And there's a large section of the US population that just doesn't have any access to maternal care. These areas in red on the map are maternity care deserts. And these are areas that mothers have no access to hospitals or birth centers or midwives or OBGYNs that provide obstetric care. And there's still a ton of births happening in these areas. Our treatment for postpartum hemorrhage is going to be a blood transfusion. But unfortunately, we're going through one of the greatest blood shortages we've seen in over 20 years. But even if we weren't going through a blood shortage, our rural hospitals only stock a limited supply of blood. 2 units, if even that. And our modern healthcare society hasn't figured out a way to really synthesize blood products yet. So we're just limited. And so what does this mean for a woman who's experiencing postpartum hemorrhage? We've heard horror stories of women being transported from one rural hospital to another, just to receive a transfusion while on their way to a facility with escalated care. So is there a solution out there already? Yeah, it's autotransfusion, but it's not the right fit yet. This is a solution for some bleeding patients, but not for postpartum hemorrhage. The traditional autotransfusion machines are confined to the sterile OR. You need dedicated operators to run them, and the machines that they keep coming out with just get more and more and more complex. We want to introduce you to our solution. Our device allows bleeding patients without access to blood transfusions or trained staff or sterile ORs to now receive their own blood. Meet our emergency autotransfusion device, Bevel. The way Bevel works is by collecting blood from mom during a postpartum hemorrhage. And we do this a couple different ways. We can use V-drapes, Bakary balloons, or the JADA system, or even just a suction line. And then we mix the blood with an anticoagulant that prevents clotting. We then concentrate red blood cells in a centrifuge, and we wash out other contaminants like amniotic fluid. We're then able to pass that blood over a germicidal UV light. And from there, we have a finished blood product. It's the patient's own, it's clean, and it treats postpartum hemorrhage under 5 minutes. So Bevel uses UV light technology to clean blood beyond what other traditional autotransfusion machines do. And the way UV light works is by destroying bacterial DNA. The great thing about red blood cells, they don't contain DNA, so they're left undamaged. UV light can even treat blood within seconds and makes Bevel perfect for emergencies. Because we use UV light technology, we can take autotransfusion outside the OR. We've designed Bevel to travel. We've included handles and bed hooks, so Bevel can go to home births and labor and delivery suites. And with its 2-hour battery life, Bevel can go in an ambulance while mom is being transported for escalated care. We're placing Bevel in the hands of midwives, ambulatory services, and rural providers, all the areas that traditional autotransfusion has never gone before. And out of all the companies presenting here today, we are by far the youngest. We're only 3 months old. We are developing our prototype right now, and we're going to begin bench testing in a couple months. And we plan to finish this year out with an FDA 510(k) submission. There's a much larger team behind me that has helped propel this idea forward. We have a great team of founders, doctors, scientists, lawyers, and business experts that have all supported our progress in one way or another. And this leads me to my last slide, my ask to you all. If this solution for postpartum hemorrhage speaks to you, we need your help. We're looking for advisors across multiple industries, medical and business. And if you believe this device could help your patients, we want to work with you. And lastly, we're looking for funding. We're still early on in our development, so angel investors and the like, we're speaking to you. We've added a QR code that goes to a contact form and also my email, so you guys feel free to reach out. And so from all of us at Bax Medical, thank you for your time, and I'm ready for questions.
Well, thanks for your presentation, and congratulations on a lot of progress in a very short amount of time.
Thank you.
So I'm not going to ask about economics, just to sort of shake it up, although if I have time, I'll ask a later question about it.
Okay.
I'm curious about you talked a lot about the maternal deserts as your sort of target segment. Is that illustrative of the need, or is that the primary, like where do you see this being used, or is there a type of hospital that's ideal? Is it limited? Is it everybody? How do you think about your target?
Yeah, so maternal care deserts, I think of kind of like the most resourced areas. And so they're going to be the worst of the worst. And I definitely believe that this would be in this area. But I don't believe that it's going to be the only location that we're going to be providing the Bevel towards. So I think this is also a place for critical access hospitals as well. And I've started to initiate talks with critical access hospitals, specifically in Illinois, but we'd like to branch out to other locations in the other states. And so, there's other areas as well that we're hoping to target is then midwives and being able to provide this device for midwives who are going to be treating home births. EMS, having this in EMS. And I might have alluded to some of this on some of the slides here, but Bevel can go beyond just postpartum hemorrhage as well. So we're looking at also treating trauma patients with this device too. So it's not just maternal care deserts, it's really these under-resourced areas that have a limited supply of blood available to them.
And just a quick follow-up, is that because the larger centers have these big, complex, expensive systems already, and you don't think there's a need, or you don't think you would displace them, or is there a future opportunity?
So being an owner of one of the largest providers in Chicago for auto transfusion services, I can't get my machines and my staff to those rural sites. And those rural sites, yes, we could put a machine there, but they don't have the staff capable to run that machine. They are also limited in that capacity as well. And so, this is one factor where I saw like the problem getting worse with the designs of these auto transfusion machines. Big hospitals like University of Chicago or Lurie's, where we're working at, they have a lot of resources. They can afford the extra labor. But I know that there are these hospitals that just can't get this to their patients. And what's even worse is their stock of blood products is much lower than University of Chicago or Lurie's or other facilities in a metropolitan area.
Thank you for your presentation. Couple things. So we've looked at this in obstetrics before, and it's challenging. Because as you know, when you deliver, there's meconium, there could be amniotic fluid. It's a dirty sample. So infection, I know you talked about the UV light, and it sounds like has there been any bench work on, because it sounds like there's been no studies. Just walk us through that, what this looks like as far as conceptually, because that would be a really big concern. It's already a concern with blood transfusion, even in the cleanest with the fanciest, and I use cell salvage systems all the time, right?
So a lot of this, I think, work with putting autotransfusion, autologous blood in obstetric cases has developed significantly over the past decade. And so there is a group, I believe they're out of Pittsburgh, one doctor, Jonathan Waters, who's done a lot of work on getting autotransfusion into obstetrics. And he's started out at like building in autotransfusion into cesarean sections. And in autotransfusion, so other people can understand this, is the relative contraindication to using autotransfusion in obstetrics is two factors. It is amniotic fluid embolism, and then it is also, with specifically vaginal deliveries, having a higher microbial load, and your circulatory system is a sterile environment. So if we're collecting bacteria, we don't want to reintroduce that bacteria into a transfusion. And so Dr. Jonathan Waters has done a lot of research and has been able to kind of push this into an environment where there is data to support it in a C-section, right? And he's starting to do vaginal deliveries as well. But we're trying to make this an even safer procedure and escalate that process further by including that UV light technology and going beyond the OR so we can get to all of these other locations. And so the goal is, at some point, as we develop out our prototype and make it equivalent to current machines, the standards that those machines have, is that we're going to try and get that and validate that in these other environments. The other factor we're dealing with, too, is that when we're dealing with a mom who this is a life-saving treatment, we have to look at the risks and the benefits of what we're doing. If mom is going to die because she doesn't have a blood product, let's give her a blood product, and then we can maybe treat with antibiotics as well. And so this is still kind of an ongoing process,
That would be litigious, so we won't go there today in this room.
Again, I remind you, I'm only 3 months old. So.
I just want to make sure that you're addressing what my root question is. Have you done any bench research of your UV light technique and the microbial load? Because really we're talking about contamination.
Yes.
Right?
Yes.
And
so
how does it resolve contamination?
Yeah. So we've done initial validation studies, and the validation studies were just like, it was like night and day. We collected samples, we had mixed in E. coli, and then we had used the UV light on blood, and we had non-blood our control, and we grew some of the grossest cultures in our non-UV light samples, and our UV light sample was clean. And that we reported at Society for Advancement of Blood Management, and that was kind of our, okay, you know, this is showing some promise here. We're going to do further studies, and so at UIC, we have the infectious disease doctor, Dr. Omar Perez, who we are going to continue to validate a lot of these studies. And then we also are going to be working with Dr. David Allison in hematology and blood bank to then use the prototype and larger sources of whole blood to really prove out this concept even further.
Okay. And I just want you to think through it a little bit. Most of the time when individuals have home births, they don't have IVs, right? And so you illustrated to us a collection system, but out of your system, how do I then get that into a patient?
Yeah.
And so there seems to me I'm missing a step.
The IV.
And so, yeah,
It's
there's
the
still
IV.
going to have to be another collection system to get it. But typically home births, they're not doing IVs. That's one of the reasons women choose that, right? Non-invasive.
Yeah, but at that point, I know that the midwives can put in IVs.
That means you got to be clear that a midwife would have IV supplies, right? So there's a whole process. I'm just giving that to you to think through in your work stream.
Yeah.
Okay?
Yeah, and all these conversations we're still processing through, and we're still doing a lot of collections and like building out this resource. And so, yeah, a great point, and something that I'll be making sure that, like, usability-wise, that we can make this happen in that home birth with a midwife.
All right. Ethel, do you have? You can ask a quick one if, yeah, go ahead.
Well, hopefully, I don't know if it's So is UV light, so thank you for your presentation, very intriguing. Is UV light used in the current device?
No.
So that's my question. So you mentioned in your slides that your FDA pathway is a 510K, and why do you think that's going to be accepted as a predicate device?
So, what, so in talking to our FDA consultants, we decided on a path to kind of easier, like getting in through the FDA and also earlier to market as well. And so what we would be doing is we would be building the device to, actually not even, we don't change anything with the device, but we're not making any new claims yet. We are saying we are building a device that is autotransfusion that contains UV light. And both of these things do two things that have already been medically cleared by the FDA. Autotransfusion is medically cleared by the FDA to treat patients in an OR to clean blood and return it back to the patient. And the UV light aspect is also cleared as a germicidal light. And so we're combining these already present claims together to get it an easier path into this and a place for earlier revenue as well. And so as we build up data and as we work with pilot sites, we are going to be talking to EMS, midwives, to try and build the data and research behind this, so then we can take it back to the FDA to make that additional claim. Good?
Yes, great job, Katie.
Thank you.
All right, we are going to take a 5-minute break to stay on schedule. So we'll reconvene with the next pitch at 3:50.
Hello, everyone. Thank you. I am Dara Cook, CEO of Expect. We founded Expect because women in America today are more likely to die from pregnancy complications than our grandmothers were over 50 years ago. And for the first time in 20 years, our infant mortality rate is rising across races. These deaths are the tip of the iceberg. Up to a third of women are experiencing some complications, from C-sections to gestational diabetes and more. But what makes this so unforgivable is that we can prevent this. My sister is a great example. Despite being at an age when the odds of complications were high, she had a smooth pregnancy and a 20-minute active labor. Her OBGYN credited one thing that set her experience apart. She exercised during pregnancy. Maternal fitness is proven to reduce the risk of everything from premature births to postpartum depression by double-digit percentages. Babies benefit with stronger hearts, better brain development, and lower rates of diabetes and obesity into their adulthood. The clinical evidence is so strong, all of the world's leading health institutions now recommend regular pre- and postnatal fitness. The problem is many pregnant women don't work out because, rightfully so, they don't know what is safe and find the few prenatal options unmotivating. And that's why I left my 20-year career at MTV, where I learned how to captivate millions, to move people in another way with Expect, fitness optimized for pregnancy and postnatal, and the only platform where every workout is approved by OBGYNs. We make fitness addictive with music video style production and unparalleled diversity of race, gender, and body type. Because we are OBGYN approved, we can provide the broadest fitness variety in the pregnancy space with 3 times the prenatal content as Peloton. Each workout includes detailed doctor's notes from the OBGYNs who approved it, and we give moms everything they need to exercise. They can ask our OBGYNs questions, connect with other moms, and browse educational content. Now, McKinsey & Company selected Expect as one of only 3 SoCal startups they would consult for pro bono, and as part of their engagement with us, they conducted a competitive maternal fitness survey that found that moms rank Expect best in class for their most important criteria, safety. It would be easier for a competitor to buy us than to build us. Here is the team behind Expect. I bring my experience as head creative of the MTV Video Music Awards and brand manager of Wild 'N Out. I'm currently a visiting entrepreneur at Stanford GSB. Our co-founder, Joey, who will be joining us virtually for the Q&A, brings his experience as a YC-backed startup engineering and product thought leader who has interviewed and coached hundreds of Bay Area engineers. Our CFO, Chief Fitness Officer, Emmy winner Jillian, was head of production for ClassPass. Our special advisors are Harvard Medical School professor Iman Lee, who co-authored the landmark studies on the impact of prenatal fitness. She's in an exclusive contract with us. And Dr. Rachel Villanueva, who, Dr. Lawson, you may know her as the previous president of the National Medical Association. Now, what we have accomplished is something that no other maternal fitness company is coming close to. We have operationalized an entire medical review process, and that is driven by 16 OBGYNs representing some of the top medical institutions in the country. These OBGYNs review and approve every workout in the Expect platform for safety, for complication relief, and symptom relief. The big headline, Expect is a healthcare company with the direct-to-consumer appeal of an entertainment company. And as a healthcare company, our business model is to sell into employers, providers, and insurers because maternal fitness reduces costs, saving payers an average of $3,000 per mom. Expect subscriptions are $500 a year, delivering tremendous value. Now, this is the economic reality that's driving the need for Expect in our traction, is that women of childbearing age are almost 3 times more expensive to insure than men of the same age, largely driven by the high cost of pregnancy, childbirth, and largely preventable pregnancy-related complications. Expect is solving a major pain point for any institution that is financially exposed to the high cost of pregnancy. Now, here's a look at our tremendous traction. We are thrilled to announce an IRB-approved study with the University of Alabama at Birmingham, which is the #5 OBGYN department in the country. Expect has also entered into a collaboration with the Veterans Affairs to co-develop a VA-centric version of Expect. The VA is the country's largest integrated health system, and women are its fastest growing demo. And in the largest validation of our business model, we have signed on our first payer. Expect is now reimbursable under .32 Health, which covers 2.2 million lives. Now here's where we're headed. Contracting with the Veterans Affairs, extending our relationship with the federal government to provide Expect to active service women under the Department of Defense. All of those women are of childbearing age. Contracting with a major employer, doubling down on our momentum with payers and signing on yet another major insurer, and continuing to prove out our clinical validity through studies with major academic institutions. Now, I'd like to leave you with this. A few years ago, the University of Michigan released a report that said, giving birth is as hard on the body as running a marathon. Yet curiously, we have been expecting women to undergo this ultimate endurance race of pregnancy and childbirth without physically training for it. And when you understand that context, it's not then surprising, as Dr. Cherot explained earlier, that the leading cause of pregnancy-related death in this country is cardiovascular related. Expect is here to solve this maternal health crisis through the only maternal fitness platform that is backed by OBGYNs. We are requesting introductions to employers, insurers, and hospital systems so we can empower moms to train for the highest stake marathon they will ever run for their lives and the lives of their babies. So we thank you, and we look forward to your questions. And I'll get Joey on as well. Here he is from California.
Okay, I'll start. Thank you for your presentation. I have one quick question that I just need understanding on. What clinical outcomes specifically are you trying to address? I mean, I think we all know the importance of exercise. That's one piece. And then my second piece is risk analysis, waivers, that kind of thing for pregnant women, because while an OB-GYN could look at the exercises, it depends on that individual patient's status before we would endorse particular exercises. So two-part question, and let me know if you need me to repeat.
Yeah, sure. So I'll start with the risk analysis. So we know in general that it is safer to exercise in pregnancy than not to exercise. But we have a 4-layer approach to risk analysis. So before any woman can engage with the Expect platform, they are signing on to terms and conditions stating that their doctor has approved them to exercise. Our attorneys say we have a belt and suspenders approach. So each workout includes the stages for which that workout is approved, and then the medical disclaimer. Most platforms don't have that level. We're also carrying millions of dollars of insurance as well. And then we have a social media outfit that is looking for any potential, we haven't seen anything, but any potential complaints, et cetera, so we can get ahead of these things. And your question, that was the first question that Dr. Ayman Lee asked us before she signed on to be our medical advisor, was this question about risk.
So you don't require a note from their doctor that they're cleared for the program or anything? I'm just asking.
It's not a doctor's note, but it is what in order for them to even get into the app, they have to say, I have been approved by my doctor to exercise.
So it's self-attestation.
It's self-attested. Yes, absolutely. And I'm sorry, and then the other question was about,
the second question about clinical outcomes.
Yes,
you
clinical outcomes,
pilots and
absolutely.
trials, but what clinical outcomes specifically?
Yes, okay. So there's the IRB approved study that we have at University of Alabama at Birmingham, that is testing engagement, right? So that's about whether women who have access to Expect exercise more than women who don't. The next two steps, and we showed that sort of in our where we're headed, two things. Number one, testing the impact of expect on gestational diabetes. So gestational diabetes in particular is the condition that is most impacted by exercise. And we're focusing on women with PCOS. We work with the amazing Extend Health on some of this work, and they're here in the building right now. And then next, we've been having conversations with Penn Medicine about testing the impact of expect on postpartum depression. As we know, suicide is a leading cause of death postpartum. So that's the next step, is beyond, and this is where we differentiate from any of the other maternal fitness platforms out there. Our plan is to provide clinical evidence surrounding our impact on specific conditions so we can make specific claims and say that expect reduces gestational diabetes by X%, reduces the risk of postpartum depression by X%.
Hi, thanks so much for your presentation. So how many users, what's your track so far, how many users?
So we're really just starting. So we have our first big client is Point 32 Health, and we just became reimbursable under Point 32. And they're launching a huge marketing campaign for us. So again, they are at 2.2 million lives, and we have a number of other conversations with other major insurers.
Have you done any thought about, your customer demographics? Like, what are you looking for as far as age, wage, race?
Yes, absolutely. So we were fortunate to have McKinsey & Company do a tremendous amount of this work for us, and most startups don't have that opportunity. So we have 5 customer archetypes. The easiest customers to adopt are customers who are already exercising pre-pregnancy and they want to continue exercising in pregnancy but just don't know what they can do or what's safe. So these are the earliest adopters. In terms of impact, and we speak to our advisors about this all the time, the biggest impact is to move the sedentary into some level of activity. And so that is the Medicaid population you're talking about. And that is why, and I love what Dr. Cherot said earlier today. She was like, if you're solving for certain demographics, you're solving for everyone. And that is another point of differentiation between us and other maternal fitness platforms. If you've ever seen any maternal fitness out there, it is catered towards one archetype. It's the yoga mom from New York and LA, and they, and these platforms, including Peloton, have ignored women of color. And I love what Dr. Cherot said, if you solve for black women, you're solving for the problem. Obviously, we are centered in this diversity and equity, and I think this is why we've been able to gain adoption with Point 32 Health and the VA, because these are institutions that are rooted in health equity. VA is more racially diverse than the general population. They're over-indexing on complications, unfortunately, amongst our most intrepid women. So we are really solving for impact with the group of women who can benefit the most from exercising in pregnancy.
Thank you. I loved your presentation, and when the videos were playing, I wanted to get up and exercise. Yeah. So I think you're onto something because, I did some prenatal yoga videos. They're very slow and sleepy. So this is great. 2 thumbs up. So question for you. I hear you saying, payers are your sort of target. You're going to try to unlock coverage. And then where do you go from there? How do you bring patients in or physicians in or both? Are you doing direct to professional? What's your marketing plan?
Yeah, absolutely. So we're doing a few things, and luckily, I'm coming from this world of MTV where this is what we learned how to do, is how do you excite the masses, right? So on top of contracting with payers, we're starting an entire influencer campaign. So we have a small cadre of influencers, mom influencers, fitness influencers, to spread the word about Expect, and then also utilizing providers themselves. So this is in the existing workflow because the American College of Obstetricians and Gynecologists has been recommending for several years now pre- and postnatal fitness. This is in the workflow. Doctors are telling their pregnant patients to exercise, and all the doctors on our advisory say the same thing. They say, the women then say, well, what can I do? and then they don't have any place to send them. And so that was one of the main reasons we got so many of our doctors on board. So reaching out to doctors, and a lot of them are all, they're organized by these hospital systems, our own OBGYNs. One of our most active is with University of Chicago Medicine as well, and they're an important part of that as well. So using direct-to-consumer means, and the last piece is working with existing communities, right? So there are very active communities of moms who exercise, women who exercise, and tapping into these existing communities to spread the word about Expect beyond just the payer, health system, employer routes, which can be a little dry, right? So we're trying to bring some of the fun ways of engaging people that we learned from the world of entertainment. Thank you so much.
Great job, Dara. Next up, we have Ritam from Alethea.
Hello, everyone. I'm Ritam, and I'm the CEO of Alethea. Now, it's clear and no secret that we have a terrible maternal health crisis in this country. Yet despite this, the vast majority of our moms never needed to suffer from life-threatening complications. And the reason top academic journals cite for this is because we do a terrible job of catching these moms early. We have a system that is fundamentally reactive and not proactive. We wait for our moms to have life-threatening admissions and then do damage control at the point of delivery. The closest we have to early identification is we use remote patient monitoring, like blood pressure cuffs, or blood screening panels at prenatal visits. But the biggest issue here is that they wait for moms to have underlying pathology of disease take place. We wait for the underlying disease processes, like hypertension, to already put mom and baby at risk before we start intervening. There's a desperate need for a kind of solution that captures these moms at risk as soon as the first month of pregnancy, before there's any physiologic onset of these life-threatening complications, to truly achieve some kind of prevention. And one of the biggest tragedies in maternal health care is that we actually have every kind of social and clinical intervention we would need right at this point. For moms on Medicaid that can't get to their appointments, that can't pay for rent, or can't put nutritious food on the table. And for moms that need any one of dozens of clinical support services, ranging from doulas to mental health to substance use behavioral programs, all of these are completely and freely accessible to every single mom in America that's on Medicaid. And yet, less than 10% of moms actually benefit from these life-saving resources. And anyone that's been pregnant in this audience probably didn't even know that half of these were completely freely available to you. And the true story of why that's the case is because these resources in reality are fragmented. They're hidden on page 39 of a 70-page member handbook. They're on some obscure link in some terribly designed site. And intuitively, if you as a mom don't know what a perinatologist is, then how can you be expected to seek one out to benefit from it? And the only thing that moms currently have are what's called care managers. Now, insurance health plans hire nurses and PAs, who are care managers, to contact these moms through manual phone conversations. And here lies one of the biggest misallocations of healthcare labor in healthcare. These nurses are given the job of call centers, where they're manually calling hundreds of numbers each and every single week. And in that extremely manual process, they're missing over 80% of high-risk moms across the country, leading to tens of thousands of dollars of preventable spend. This is what Alethea aims to solve. We have a two-part solution. Firstly, we use machine learning models at the point of care, as early as the first month, to predict risk of life-threatening complications, like preeclampsia, preterm labor, postpartum hemorrhage, and emergency C-sections. We are able to go and use basic clinical history and demographic information straight from claims data. So we don't need our users to download any app. There's no need for information from the mom or EHRs. It's straight from the insurance plan, so 100% patient penetration is possible. And when we tested these models on moms like these, on over 3 million moms across the US and 4 African countries, we saw that we could catch 3 to 5 times as many complications as even Harvard doctors could using the national gold standard on Harvard patients. But unlike these Harvard doctors, we could catch these moms 6 to 8 months sooner, allowing for earlier identification. And we're in the process right now of conducting the largest ever randomized controlled trial across 4 African countries and Beth Israel at Harvard. And we're a couple months away from getting these results. And once we have these kind of these risk notifications, we pass it on to who we call Clara, our AI care manager. Now, Clara is an AI employee of these health plans, which is the next frontier of where the labor force is going. We all know that we don't have enough clinicians for too many sick patients. And this is where Clara fills the gaps. Clara has perfect understanding of every social need resource that a member is eligible for but not enrolled in. And she also has perfect understanding of what care delivery structures that a member can need. We, on the back end, partner with telehealth organizations for doula care, PTs, NPs, and so on. And we route these to Clara, who condenses this and gives it to each member. So Clara is able to interact with each mom through a real-time text message or real-time phone conversation and talk back and forth with them and answer questions just the way a real human would. But unlike a real human, Clara can speak any language. She's up 24/7, and she's available for a fraction of the cost. And best of all, she can do defined actions, like do prenatal depression screenings, postpartum depression screenings, and even apply for Medicaid in as little as 5 minutes instead of the status quo, which takes 3 to 4 hours. And to illustrate the impact that Clara actually has on members, I want to share the story of Marissa, who's an actual patient I worked with at the wards and illustrates multiple member experiences of patients we're impacting with Alethea. Now, Marissa is a mom on Medicaid who lives in a very rural region. After her first prenatal visit, she didn't realize that her Medicaid was being redetermined. So as a result, she actually lost access to Medicaid and didn't know it. So for all subsequent prenatal visits, she was turned away from providers who couldn't get their services reimbursed. She didn't know what signs to look out for her uncontrolled hypertension, and as a result, couldn't even afford medication for it. And tragically, in her 3rd trimester, she was rushed into the ER, had an emergency delivery due to preeclampsia with severe features, and horribly lost her child. And this was a terrible thing to see both her go through and to know that us as the care team could have completely prevented. And I want to show you what Alethea could have done for Marissa if it was available those years ago, and show you what it's doing for patients right now as we're live. Alethea would have known that Marissa and patients like her are at risk of preeclampsia right from the first month, before any kind of uncontrolled hypertension. From that point, in that first month, from her language of choice, she would have gotten a real-time call or multiple text messages and follow-ups to ensure engagement and be able to orchestrate clinical and social care that she's eligible for. And in 60 seconds, I want to show everyone, instead of telling, what that actually looks like in real time, pretending to be Marissa, getting that call from Alethea. So, sorry, just accessing, my bad. I'm so sorry. Give me like 10 seconds. My phone accidentally X'd out. That's embarrassing. There we go. Sorry for the wait.
Hi, Marissa. It's Clara, your AI assistant from your Elevance Medicaid plan. We're concerned that you might be at risk for preeclampsia, a blood pressure-related complication. To make sure you stay healthy, we can get you a free hypertension kit and schedule you in with a registered dietitian who specializes in preeclampsia prevention. How does that sound?
Well, I really don't know if I have the money to pay for this. And also, I have an important 51 Labs presentation coming up and don't know if I have the time.
No worries, Marissa. Everything your Elevance plan offers is absolutely free to you. You won't need to pay a dime. I can help you in less than 2 minutes if that works for you.
Let's do it.
Great. First, we can send you a free hypertension care kit that has baby aspirin, a preventive medication, and tools to help you track your heart health. Should we send it to your address on file on Wallace Boulevard?
I actually moved to 123 Harris Avenue.
Got it. I'll update our records, and you should receive your kit at 123 Harris Avenue by this Friday. Next, I want to schedule you in with Shelby, a dietitian who specializes in preeclampsia prevention. You can meet with her through telehealth appointments from the comfort of your own home. When would be a good time for you to see her?
How's Fridays after 3?
That's perfect. She has a 3:30 p.m. slot available this Friday. Can I book you in?
Yeah, let's do it.
Great. You should have just received a confirmation text with your appointment details. The last thing I wanted to mention is that you are eligible to have your Medicaid coverage renewed in June. I'll reach out to you then to apply for renewal on your behalf, if that's okay.
That sounds perfect.
Awesome. You're all set. Hope you knock that 51 Labs presentation out of the park.
Thank you. So supportive. And that's really what we're doing with Alethea, and just a taste of what Claire is capable of. We use the most evidence-based resources and evidence-based interventions, and multiple of our studies have been published in the Green Journal, in SMFM, and our flagship study just got approved by the senior editor at Nature Medicine. We're joined by an awesome team of physicians, health plan directors, and computer science PhDs, and we are excited to talk to anyone in the audience associated with either a health plan or a managed care Medicaid organization. And together, we hope that the future of maternal care can not be missed calls or faxed applications. It can be Alethea. Thank you.
Thank you so much for the presentation and the demonstration. Very interesting. Well, since you mentioned plans and you're looking for people with plans, we are also a payer. So help me understand, as a payer, how is this valuable to us?
Totally. So a couple of different ways. So firstly, right now, you're spending about $10,000 per member on these preventable complications. And like any payer, you really struggle to get these Medicaid moms or these moms in rural regions who aren't going to prenatal visits, who aren't going to postpartum checks. And your HEDIS measures involve like how many moms can you get to these postpartum depression screens, prenatal visits, get them on WIC, and so on. And less than 50% are on WIC. About 25% aren't going to these prenatal visits. And currently, your care management staff, hundreds of numbers, they're missing 80% of the high-risk ones. So that's where Clara comes in. She goes and makes sure all these members are engaged. She doubles your HEDIS criteria and cuts your rates of preterm labors, preventable NICU admissions, all in half. Right now, like I was kind of saying, there's this capacity mismatch where you have all the interventions, and organizations like Parkview, you have free transport for these patients, you have other free social resources, but getting those resources to the patient in an accessible front door is hard. Many people, they don't even have smartphones, downloading apps is tough, so on and so forth. So to be able to get it in real-time text or phone calls, and literally in any language, I didn't show this, but she could have talked to me in Spanish or Portuguese or Hindi, that's a really huge value add.
Great, yeah, thank you for the presentation. Going back to if I understood this correctly, you articulated that when a patient comes into the plan, the machine learning digests their claims data, and that's how it identifies risk. Is that correct?
Yeah.
And so how does that work if a patient is, just coming onto Medicaid as a benefit, because you're targeting Medicaid patients, right? And a lot of patients get Medicaid coverage around pregnancy. So tell me, will there be claims data?
Yeah.
What is it digesting?
So
are there other ways to get the risk
and this is
factors?
an important use case. So pregnant mom just comes in, her historical claims record is there. So the data that we're using is like demographic data and then previous clinical history. So stuff like, did you have a previous C-section, or what's your age? And those kind of things are already on file. So our machine learning models intentionally are very constrained to these variables. So we don't use something like how long is labor, or do you have eclampsia, which is all the way in the 3rd trimester, so that we can make these early stage predictions and route the resources at early stages.
But then are there other opportunities to update the risk factors? Like, does the physician interact with the system in any other way, or it's just limited to these early stage?
So it has capacity for taking in those more complex variables. So places where we integrate on the provider level, we take in like gestational diabetes, gestational hypertension, all those criteria. But for the health plan case, to scale to all members without needing that deeper integration, that's why we chose to go that route.
That was really my question also, how is it? But the information, it sounds like this is very payer-facing, not provider-facing,
I had
correct?
appendix slides, but I don't think they're here.
You have more slides?
I had appendix slides, but I don't think they're here. But I can just kind of verbally. Oh, sweet. Can I just get that? Yeah.
This one?
Yeah. Oh, sweet, yeah. So these are like the variables we look at. So on the payer-facing side, we kind of constrain ourselves to these two, just so it's more, it can scale for any patient at early stages. But when we do clinician-facing stuff, like most of our randomized control trials, that's all clinician-facing. We include the gestational period variables, stuff like infections and gestational diabetes and things like that.
Thank you. I just had a comment about, is it her name Clara?
Her name's Claire, yeah.
Clara?
Yeah.
Clara has to use language that a patient would understand.
Yeah.
They would not know what hypertension or preeclampsia,
Right.
right? So
Yeah.
Clara has to, so I would just use
Right.
equity language.
Yes, thank you.
Thank
Yeah,
you.
this was a demo, so we, on the actual patient-facing side, it's a little bit longer, so she explains things.
Okay,
But
thank
yeah,
you.
thank you. Thank you very much.
Great job. Okay, next up we have Kelsey from Arbor Medical.
Hello, my name is Kelsey Mayo. I'm an engineer, I'm a mom, and I'm a survivor of hemorrhage. My lived experience and my passion for translating science led me to co-found Arbor Medical, where we are pioneering wearable innovations that safeguard maternal health. We've heard a lot today about hemorrhage, and it's clear that it is important to tackle hemorrhage because it is the global leading cause of maternal death. And we've also discussed a lot about how this is not only a problem for maternal mortality, it's also a problem of health equity, and it's an economics problem, costing the US healthcare system nearly $2 billion every year. But I'd like to actually focus us for a moment on one additional point. It is absolutely important and critical that we save maternal lives. It's also important that we improve outcomes more generally, because for every mom who dies of a hemorrhage, there are 100 more who have devastating complications. But I'd like to turn this and actually be a little bit optimistic here, because there is a path forward. With early detection and earlier treatment, this is 90% preventable. Unfortunately, providers need better tools. The current clinical standard of care focuses on visual blood loss estimation, weighing blood-soaked pads, and frankly, this is subjective, it's inaccurate, it's inefficient on our already overburdened healthcare system and workers, and this is delayed. So not only do providers need better tools, but frankly, families, moms, we need better tools as well. Our team at Arbor Medical are experts in engineering equitable diagnostics. So we looked at this problem, we rolled up our sleeves, and we invented a new standard of care. Maternal Armor. Maternal Armor is a wrist-worn, non-invasive blood flow monitor and app that alerts providers to early hemorrhage and tells them whether or not their treatments are effective. Our patented technology works by monitoring the changes in blood flow in the patient's periphery that happen at the onset of a hemorrhage, when the patient starts pushing blood from the periphery to their core to protect vital organs. This solution is objective, it's accurate, it monitors things in real time so that providers can stay one step ahead in detecting hemorrhage and treating hemorrhage. We have already done extensive validation showing that early accurate detection is the solution. This validation has included IRB-approved clinical studies at our partner institution, Washington University in St. Louis. And frankly, the results from these studies are outstanding and give us confidence in our ability to deliver this solution to the market in mid-2026. The healthcare systems that we've been speaking with are eager to improve patient safety and reduce the cost of care. And Maternal Armor is a solution that enables them to improve maternal outcomes. It enables them to reduce costs of care, optimize resource utilization, and reduce the burden on their already overburdened healthcare staff. So this is not boiling the ocean. This is a concrete, cost-effective way to save lives. We're excited because in talking with our customers, we've validated our product market fit, and we're starting with hemorrhage monitoring in obstetrics. But I'd like to take a pause for a second and recognize that we have built a platform technology that our customers are actually telling us they'd like to use in other service lines and indications. And so we are going to start in obstetrics and expand moving forward. When we look at the market, we have some key competitive advantages. Specifically, we enable real-time automated monitoring of risk throughout labor, delivery, and the postpartum period. And this works across all patients, all different skin colors. We have to address this problem for everybody, and health equity is at the core of our mission. As I mentioned previously, we've made tremendous progress, including the clinical studies I cited. Our potential and our progress have actually allowed us to earn nearly $2 million in funding, non-dilutive funding, including from the NIH and the CDC. We've used this money to de-risk our business, and we're on track for regulatory approval and launch in mid-2026. We're kicking off a $1.5 million pre-seed round, and this will enable us to manufacture our clinical units and initiate our pivotal study next year. The team I couldn't be prouder to be a part of is on the screen here. We have collectively more than 75 years of med tech experience, and we are united by a shared interest and mission to solve this problem for moms and providers all across the US and beyond. We're also absolutely honored to be a part of a growing community of partners, and we couldn't do this without them. And so I would like to thank, many of you are actually in the room here today. Thank you for your support. Thank you to 51 Labs for being a part of our journey. We're so excited to expand this community. So if you're sitting in the room today or you're listening in online, and particularly if you may be a clinical site that would like to work with us and partner with us in a pilot, please contact us. We would love to work with you. So I'm going to conclude the presentation today with just a look forward at a future that I actually think is very positive. Together, we are going to save lives, and we are going to enable access to the highest quality of care for all patients, regardless of demographics or geographics. Thank you for being a part of our journey, and thank you for listening today. Okay.
Thank you for a great presentation. I was wondering if you could go back a few slides. You had a map of a few of the different technologies out there. Oh, good. Yeah. Okay, we all just need a minute to pause and read all the great words here. Can you just talk us through this a little bit and your differentiation?
Yeah, absolutely. So here we have the sort of current clinical standard of care, and I sort of shorthand this as visual blood loss estimation, recognizing there's been a lot of work in the community, particularly if you look at groups like AIM, that are expanding the use of quantitative blood loss measurements. But some of the key disadvantages of this technique, if you're doing this, you're insensitive to internal bleeding. And we all know that one of the primary causes of maternal hemorrhage is uterine atony. And so sometimes this blood can remain pooled and hidden in the uterus for hours before clinicians are able to see it and make that diagnosis. And so you can see here that we have a lot of improvements we can make. Currently on the market, there's a group called Triton AI. They are a fantastic sort of step forward in this, how do we automate quantitative blood loss measurements. But again, I still think there are some key opportunities here because while this is a solution that essentially automates the process of measuring the blood, either in the blood-soaked lap pads or if you're suctioning out a patient from a C-section, to me, this is still not giving you that real-time risk assessment in the cases of internal bleeding as well. I'm really proud, actually, that our community of innovators is expanding. And so you can see here 2 companies, including one that presented today, that I have deep admiration for, because what they're doing is working on an important piece of this problem, and that is prediction. How do we better predict people that are at risk for a hemorrhage? Our differentiator, we can be adjacent to these technologies because what we do is we monitor the changes in peripheral blood flow throughout labor, delivery, and postpartum, which the OLLI system, for instance, is more pre-delivery. And what we're able to do is see, is that treatment effective? So we had a mom, she had just delivered twins. We started monitoring her after the placenta was delivered. And in our data, we saw when the rate of blood loss outpaced IV fluid administration. And frankly, the anesthesiologist that was watching the data was thrilled. And he was the one that said, I want to see this in the ICU. I want to see this in the ER because they want that information to understand treatment effectiveness, not only in obstetrics, but in other service lines. You're welcome.
So actually my question is about other service lines. Having spent some time in cardiology,
Yes.
you know, looking at peripheral vascular flow and how they do the studies today, do you think this is a technology that could be used in those areas?
Yes, we actually did in March a 23-patient study at WashU. And what we did is this was a diverse group of patients in terms of age, actual sex, so we did it in men and women. It was not an L&D study. We looked at some of these cardiac parameters, not only blood flow, but we also looked at cardiac output, systemic vascular resistance, mean arterial pressure, and compared the performance of our system against gold standards. And as you're aware, some of these gold standards are actually invasive. And so I think that's our edge here. Within our studies and clinical data, we saw as good or better performance than these gold standards, and we're non-invasive, which, as Dr. Lawson, you know as well, we don't typically do invasive monitoring unless there's a really critical need. So I see us starting with this hemorrhage monitoring and expanding within obstetrics to look at other cardiovascular complications, but certainly other service lines as well. And love to talk more about that afterwards.
My question is around, you discussed the postpartum aspect of this. Yes. How long after postpartum?
Great question.
That's
so
key.
We have been co-developing this alongside patients and providers. So we've been thinking about and learning about clinical workflows, not only from OBs, but also nursing staff, anesthesiologists, et cetera. When we go to market, we're going to be used as soon as that patient is admitted. When they're already getting their other vitals, their patient history recorded, they're going to get this device on their wrist. And then the person doing intake will follow some short steps on our monitoring application to personalize that risk assessment so that we know what that patient's baseline looks like, and we also know what their floor looks like. So we have a personalized understanding of their ability to compensate for blood loss. We then intend for that patient to be monitored continuously throughout L&D. So they would be monitored, while they're in labor and after delivery until they're discharged, recognizing that primary postpartum hemorrhage most often happens within the first 24 hours. And then in the future, we would expand into remote patient monitoring applications for secondary hemorrhage.
So have you looked at that impact to the payer community? Because hospitals, right, the charge for continuous monitoring is different.
Yes.
And it's an acuity issue. Yeah.
Absolutely, and an excellent point. One of the things I'm really proud of is we have been talking with economic buyers, we've been talking with healthcare systems. We've done detailed healthcare economics assessments, and so we've shown that at the price point, which is like $200 a patient, we can return 4x ROI to our customers, which are actually the healthcare systems, through cost avoidance and cost savings. And so that's based off of literature review and the studies we've done. But right now, over the summer, we're validating this in addition in healthcare systems in the state of Georgia. And we're working alongside of these systems to co-develop that pricing and value proposition. Because frankly, I'm not here to sell a product, I'm here to save lives. And I can't do that without the healthcare systems. And so we've been very intentional about our business model and ensuring accessibility to the people who need it. Thank you. Appreciate it.
Next up, we have Ronnie from Zaconia Medical.
Thank you. Feels good.
Yeah? Oh, okay. So I'm going to ask you to raise your hand if you have children. Now leave your hand up if while giving birth, or for the dads and partners in the room, you've also observed your wife to have had the pleasure of getting vaginal exams during labor and thought there must be a better way to do this. So I'm with you on this one. I am a mother of 3 kids, and like most women, I also went through the vaginal exams during labor that are not only painful and traumatic, but also very intrusive, because for the most part, they're done by many different providers whom the patient has never met before. I'm a biomedical engineer, and with my 15 years of experience doing this, I decided to find a better way to do this. So this is our mission. For the 140 million women who give birth every year, we are standardizing how vaginal exams are conducted and interpreted during pregnancy and labor. Our mission is to end unnecessary invasiveness, pain, and risk during childbirth. So why is this problem that we're solving so critical besides the pain and the trauma that are good enough reasons on their own? Because vaginal exams are used for obtaining key information about how labor progresses, whether it's slowed down or stopped altogether. And they're used for making critical labor decisions, like whether to do a C-section or an induction. Today, they're done by inserting 2 fingers through the vaginal canal to assess cervical dilation, how expanded the cervix is, the length of it, and how the baby is positioned in the birth canal. It is well known that vaginal exams are highly problematic. It's documented in numerous literature. It is clinicians, nurses, and women, of course, all calling to find a better way to do this. Some of the reasons for this are vaginal exams are highly subjective and have a high error rate, and that leads to uncertainty in the decision-making process. There are a lot of redundant exams that are not only costly, but lead to inefficient workflows for providers. Many women find these exams very painful and traumatic, and the risk of infection goes up with each occurrence of the exam. All of these directly affect maternal morbidity and mortality, and that's what we're here to solve. Our solution is an AI-powered imaging probe that standardizes the collection of those cervical and fetal parameters during pregnancy and labor. It empowers providers at different skill levels to take these measurements reliably and accurately. The device combines ultrasound, optics, and machine learning, and automatically provides those images and measurements on a user interface. It works with a disposable unit, and it's designed to be woman-friendly. We have a prototype, and I want to share with you a short video of how we're demoing it here. I'm using phantoms, anatomical models. This one specifically is a closed cervix, so it's considered 0 centimeters. I put it in the model, and our algorithm automatically depicts it as 0. And this one is a 5 centimeter dilated cervix, placing it in the pelvic model. And again, the algorithm will immediately depict it as 5, which means 5 centimeters. What we're offering here for the different stakeholders are substantial benefits. For patients, we greatly improve the patient experience by reducing the pain and the stress that are associated with these exams. For the first time, we are standardizing this process for providers so that they can use accuracy and data to support their clinical decision-making. And for hospitals, we offer significant cost savings, and I'll go into that more in the next slide. But these are all key components that drive purchasing decisions at hospitals, and specifically in labor and delivery. So based on an extensive research we did, based on published studies, as well as collaboration with Duke University and interviews with stakeholders, we see that a hospital with our device can save over $1.3 million a year based on 4 main areas, which are reduced infections, reduced early admissions, reduced interventions, and time savings for providers. For our business model, we have 3 main revenue streams. We're selling the device to hospitals and clinics. We expect one device per each delivery room, as well as the triage area based on interviews with clinicians. We have recurrent revenues from disposable parts that I mentioned, roughly 5 on average per birth. And we have a subscription to our global data and image bank, which will be the first of its kind, collecting those images and measurements. And these can be used for medical, educational, and scientific purposes. The cost for a hospital per patient is $129 and will be covered by existing DRG bundles and potentially by existing CPT codes for ultrasounds. Needless to say, this is a very big market with 140 million women who give birth every year. Our US market is a $500 million market where we are targeting first high-resource hospitals as well as teaching hospitals that have the highest birth volumes and a great need for increased efficiency. And the beautiful thing here is that our device is needed at any labor and delivery scenario, and that allows us to expand to emergency departments, ambulances, and telehealth clinics in rural areas to fill the gap in obstetric deserts. And this brings me to our remote home monitoring solution, which will be prescription initiated and fully covered by existing CPT codes. Our solution can increase access to care and give a peace of mind to pregnant women and better manage hospital resources. We have a great team with decades of experience. Our chief medical advisor, Professor Shalev, is with the Israeli Ministry of Health and formerly dean of the medicine faculty at the Technion. Professor Blumenfeld from the Stanford Medical Center and Dr. Tzur, who is the director of the Women's Health Innovation at Chiba, are our medical advisors. And Dr. Ali, who is a physician and a scientist with expertise in ultrasound and machine learning, is leading our product development. We're backed by Laerdal and MHub for our pre-seed investments. And we've gained great traction so far. We have 4 medical centers that are interested in collaborating with us. We have the prototype, as I mentioned. We filed for a patent, and we met with the FDA last year. We're getting great feedback from clinicians. The majority of them repeated that they would love to improve their patient experience, reduce uncertainty during the decision making, and overall, if we offer them a data-driven solution that is user independent, they would love to replace the 2 fingers with that. As for our roadmap, we are currently developing our beta prototype, and that prototype will be used in preclinical and clinical feasibility studies. Our go-to-market is planned for the middle of 2026. We are currently raising a seed round of $1.5 million to support the beta prototype development, as well as those studies that I just mentioned. And I'd like to finish with a quote from Professor Blumenfeld from Stanford Medical Center, who said that our device is poised to address a crucial need by providing an improved patient-centric and provider-centric approach for assessing labor progress. We invite all of you to join our mission in improving maternal care and outcomes. Thank you.
Thank you for your presentation. It's nice when something really patient-centered also has great outcome benefits and potential to reduce cost. So I love that it has all those angles. Thinking about demonstrating that cost burden, I noticed your roadmap has a feasibility study and then 510(k) clearance. Do you think you'll need additional clinical research following that to demonstrate the outcome impacts?
Yes, we hope to do that through the pilots. And again, we want to first tap those high-resource hospitals where our device doesn't really affect their margins that much. And using those hospitals as a resource, we could then start to quantify those cost savings that we can offer hospitals. Exactly.
Thanks for the presentation. Can you talk a little bit more about your FDA pathway? And I saw 510(k), so what your predicate device is?
Yep. So we met with them last year. We plan to meet with them again later this year, by the end of this year, to verify our path. We were a bit early for them to determine with certainty. We have, since we are using ultrasound, we believe we can use the transvaginal ultrasound as well as 2 other devices that are ultrasound-based for labor monitoring as our predicates. Again, we need their formal approval of that, which we hope to get by the end of this year. So, yeah.
Since your device is ultrasound-based, a question about hospital users, because POCUS or point of care ultrasound use has kind of gotten mixed reviews on providers doing that. So who is going to be your user in the hospital? Is it the provider who would normally do those exams, or now you opening this up to someone else?
We're definitely opening this up to someone else. So right now, the only technology that can actually do these measurements is ultrasound. But it is not used as a standard of care to monitor labor progress, because you do need to be an expert, and it's just not done like that today. What we are doing is augmenting the ultrasound with the optics and the machine learning so that we lower the barrier for who can actually use it, and we're making it user independent. So your level of expertise does not matter so much as with the vaginal exam today, where training is really extensive, and again, it's subjective. So we are opening this up to be used by all providers in labor and delivery, but also in emergency departments, potentially in urgent cares, and again, telehealth clinics in rural areas where you get trained on the device and you're good to go.
Mike, just to clarify, so you probably said this and I missed it, but the device is using ultrasound to take these measurements, not a camera? It looked like...
Both.
It's both, okay.
Both, because we are taking pictures from the vaginal canal itself, but we're also looking inside the body at the length of the cervix and at the baby's head. And so that portion is done by the ultrasound. But the machine learning is using all images to output all these parameters that I mentioned.
Okay, great. And so then you really need your dedicated box to be in the room when you're doing the exam.
Correct.
Right.
Yes.
Okay. Do you think there are other applications? Like, can you replace the standard vaginal exam where you're doing visual exam?
Right. So the idea is to completely replace the vaginal exam. Or are you talking about
like outside of pregnancy?
Outside of pregnancy, potentially, yes. I don't see why not, because again, it's using imaging and replacing something that is tactile today, can be used for other applications, as well as potentially for cancer detection if we add other imaging modalities on top of that, or other wavelengths, for example. So yeah.
Great.
Great job, Ronnie. All right, last but not least, we have Robbie from Biotics AI. Robbie.
Hi, my name is Robbie Bastami. I'm the CEO and co-founder of Biotics AI. I was raised by a family of obstetricians. My mother, her sister, her brother, they all worked in maternal care. My mother passionately worked on improving maternal care outcomes in her home country of Yemen as a physician and as a Berkeley researcher. I personally fell in love with coding at the age of 9, grew up as a total tech geek, built apps throughout my teens, and then became a data and AI engineer. But growing up around my mother's work, I became acutely aware of the growing problems in pregnancy care. Now, normally when I present, I'm normally educating the listeners on the current state of pregnancy care in the United States. But today, especially after all the other presentations, I think we're all quite familiar with how dire things are. So, we're all here for the same reason. The United States has the worst maternal mortality and morbidity outcomes in the developed world, and we're not even close to the nearest nation. Looking at the conditions that impact maternal mortality and maternal morbidity, like hydrops fetalis, placenta accreta, TGA, CDH, in addition to 300 other syndromes, There's a commonality across all of them, and that's that they all use ultrasound ultrasound is used for diagnostics across all these conditions. The problem, while ultrasound is an exceptionally useful tool, is that ultrasound is highly operator dependent, with a very wide spectrum of skill sets in conducting and interpreting prenatal ultrasound screenings. In fact, the most extensive and important ultrasound screening that's conducted during pregnancy, where the mass majority of fetal abnormalities are screened for, has a misdiagnosis rate of 50% in the developed world. When these conditions are missed during ultrasound, patients are up to 4 times higher, the risk to patients is almost 4 times higher when it comes to maternal mortality and morbidity. But at Biotics AI, we're doing something to solve this. We built an AI-powered vendor-agnostic software that can plug into any ultrasound machine to process these ultrasound screenings to improve the quality of diagnostics. Our tool localizes fetal anomalies, bringing them to the attention of the obstetricians, so that way they don't go unnoticed. Additionally, our computer vision algorithms validate the overall completeness and quality of the screening, ensuring the appropriate capture of over 90 different anatomical views and structures, providing a feedback loop to the operator, so that way if they made any mistakes, they can go back and rectify those errors. And lastly, we're helping an already overworked workforce by automating redundancy, automating reporting and documentation, and making sure we provide valuable time back to physicians. Now, we conducted clinical studies on obstetricians who had historically performed incomplete ultrasound screenings, and when Biotics AI was used and added to their workflow, the overall completeness of their screening went up by 20%. To put this in perspective, the most common reason for a misdiagnosis in prenatal ultrasound isn't that an image is appropriately captured and the interpreting physician misses the anomaly. Statistically, that's the second leading reason. The first leading reason is that the image isn't captured altogether, or the image is of such low quality that a diagnosis can't be performed on it. By making sure that these patients are getting complete screenings, we can increase the overall diagnostic accuracy for these patients. Additionally, in the study, we found that we were able to save up to 8 minutes per patient on reporting documentation time and image review time, providing value and clinical, not just clinical ROI, but financial ROI back to the health system. Now, to build out this technology, it took an awesome team of obstetricians and machine learning engineers from institutions like the University of Pennsylvania, IBM Watson, the ICOG, and Kaiser Permanente. Additionally, we've worked with some awesome medical professionals from institutions like Maimonides Medical Center and ValueWise Health, in addition to nationwide organizations like ASM, in order to provide this type of technology. Additionally, we have some awesome backers that have supported us in our journey thus far, like Matter and Laerdal Million Lives Funds. And if any of you are familiar with the show Silicon Valley and familiar with TechCrunch Disrupt, it's the largest startup competition in the world that happens once a year in San Francisco. And we came in first place last year and received a $100K grant from TechCrunch as a result. Going to the health economics, we're selling our solution to hospitals. Health systems are incentivized to purchase our solution through the ROI we're providing, where we estimate we can provide $9,000 per user per month on our platform by saving time, allowing for increased patient volume, and in the future, allowing for healthcare for patient reimbursement. To date, we've partnered with 10 health systems, and we have access to 8 million ultrasound images to develop these algorithms. This growing data that we've been able to develop allows us to build out new algorithms for new indications. So that way we can start with pregnancy care, but then move into other areas of gynecology, urogynecology, developing algorithms to detect issues in gynecologic oncology, for pelvic floor ultrasound, and so on. So that way we become the AI diagnostics platform for reproductive health. As far as how our journey goes, we have some really exciting things coming along so that way we reach our goal. This year, we're focused on getting our FDA clearance and converting our existing pilots into paying customers. Next year, we're focusing on expanding nationwide. We're already talking to multiple health systems in order to facilitate this expansion, and that's why we're here today. We're looking for health systems to work with us in our journey so we can make sure that every single patient gets the quality diagnostic ultrasound that they need. If you're interested, talk to me after the presentation. Feel free to take a picture, scan the QR code, and thank you very much.
Thank you for your presentation. Very compelling mission. And so just logistically, you have a software layer, it sounds like. Is that right? So it can work with any ultrasound machine?
Correct, yeah. So it's vendor agnostic. We can connect to any ultrasound machine over a standard API, so the standard DICOM API. And we can sit on a touchscreen tablet or laptop right next to the ultrasound machine. In some scenarios, the patient is sent off to a medical imaging center, and the interpreting physician is in the back office, and we can sit in conjunction with existing ultrasound reporting softwares, like AS software is the most common one. So we can sit alongside some of those ultrasound reporting softwares where they can use our solution for quality assurance as well.
Gotcha. So then will your route to market sort of be selling directly to hospitals and hospital systems, or is it, partnering with ultrasound manufacturers to be, a component of their machine? How do you see your sort of customer base?
Correct. Yeah, so it's a mix of both. I mean, today we can sell directly to health systems, given from a technology standpoint. So there are no limitations as to what types of ultrasound machines we can work with. From a sales channel standpoint, we are speaking to a few different ultrasound companies to facilitate that direct sales into their existing customer base. And we can work not just with the manufacturers, but also with the softwares as well. So the reporting softwares like the Kalo Medicals, the ASs of the world. So.
I guess I have a question about differentiation, because obviously AI in radiology is just exploding, and everybody's saying we can look for this, we can look for this. So what differentiates yourself, and what keeps you from somebody else just saying, well, I could feed in 8 million images and do what you're doing?
Totally, yeah. So great question. So I think in general, and you sort of touched on it in your question, every single AI company, but if we're talking about medical imaging, any medical imaging AI company is only so, from a defensibility standpoint, if you develop one algorithm, it will only take so long before another competitor comes in, develops the same algorithm, and so on. So really, to defend yourself, what you want to build is a continuous data moat, a data pipeline where you can continuously develop new algorithms for new indications and expand the platform, and that's exactly what we've done. So we do everything in-house. We annotate the data. We developed our own internal AI algorithms that actually speed up our data annotation process. So our per annotation cost is actually $0.01 per annotation today. So we move super lean. And that's really, I think, where our core secret sauce is. It comes down to the data engineering framework that we've built. So we're going to be launching more and more algorithms on this platform. So we're starting with QA, identifying fetal anatomy as part of our first release. So our first 2 core AI algorithms is what we're getting cleared. But we're going to be able to expand on that quite quickly with the way that we've been collecting data and working with these health systems.
The other part of your presentation, thank you for that answer, by the way, that was great. The other part that I thought was interesting is how you were giving that immediate feedback to the technician. Have you looked at using this in training at all? Because it seems like it could be very valuable on the training side.
Yeah, totally. And actually, in that clinical test we did, so we worked with obstetricians that had less than 2 years experience and did some retrospective analysis on their past ultrasound screenings to identify them as candidates. What we found as well is that as they used the tool, their ultrasound screenings that they conducted on their first go-around actually got better and better as they used the tool as well. So there's a total use case for working with medical schools, ultrasonography centers that teach ultrasound to sonographers for our applications. So, yeah. Thanks.
Okay, that is a wrap for today's program. Just wanted to say thank you so much to our 51 Labs cohort. It's been a pleasure working with you all over the past 12 weeks. Thank you for your hard work. And of course to our expert panelists for your insightful questions and time. We greatly appreciate it. Our 51 Labs partners, HCSC, Laerdal Million Lives Fund, Stryker, Organon, UChicago Medicine, Parkview Health, and BayCare. We greatly appreciate your mentorship and your resources dedicated to this program. Our lead mentors, Pam and Nicole, thank you. And so many of you in this room have dedicated countless hours to helping the cohort advance their businesses. So we thank you all.